Okay. Ashley, are we ready?
Yes, we're good to go.
Okay. We're good to go with cable as well.
Yes.
Awesome. All right. Good morning, everyone. I don't have a gavel here at home. I'm calling this performance oversight hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, February 12th, 2025. The time is 9:32 a.m. We will discuss the performance of the Office of the Deputy Mayor for Health and Human Services, as well as the Department of Healthcare Finance for FY 2024 to FY 2025 to date. Um, Today's meeting is virtual only, given the snow and the winter weather. So we'll have our public witnesses testifying virtually today, and we will reschedule our government witnesses for a later date, which that information will be noticed and published. The Office of the Deputy Mayor for Health and Human Services supports the mayor in coordinating a comprehensive system of benefits and goods and services across multiple agencies to ensure that children, youth, and adults with and without disabilities can lead healthy, meaningful, and productive lives. DMHHS provides leadership for policy planning, government relations, and communication and community relations for the agencies under its cluster. DMHHS also manages two special initiatives, which is the Age-Friendly DC, as well as the Interagency Council on Homelessness. It also oversees the administration's encampment clearing and closure program. The Department of Healthcare Finance provides health care services to low-income children, adults, seniors, and persons with disabilities. Over 269,000 district residents, approximately 38% of all residents, receive healthcare services through Medicaid or the Alliance programs in 2024. Department of Healthcare Finance strives to provide these services to the most appropriate and cost-effective settings possible through operations of 9 various divisions. The committee did send written questions to the agencies, and we'll reference those materials today as well as at the future government hearing. If anyone is interested in seeing those materials, they can be found on the DC Council website at dccouncil.gov/hearings. I don't see any of my colleagues who have joined us, but they probably will throughout the day, and I'll certainly turn to them when that time comes. Before we get started, I do want to review the testimony guidelines for our public witnesses. Given the large number of public witnesses that we have today, everyone will have 3 minutes to testify. I will give you a nudge when your time has expired. And since we're all, virtual today, the timer is very clear. It's in a nice greenish, Liberty green blue box. So please be mindful of that. For those who are testifying virtually today, we're going to do panels of, I think, about 6 or 7, depending on who is arriving. And then we'll go from there. Okay. So also for those who are testifying virtually, you'll need to affirmatively accept our invitation to become a panelist so that you can come on up. So we'll start with 6 for this first. Ruth Pollard, the president and CEO of the DC Primary Care Association. Richard Benjamia, who is a organizers with Spaces in Action. Huat Ugosa from Mary Center. Apologies if I'm getting your names incorrectly. Usama Sadi, the residences of Kenilworth Park. Joshua Deming, Washington Legal Clinic for the Homeless. Trupti Patel, ANC 2A. I'll give it a minute as folks join. Okay. All right. All right. I see Ms. Pollard, so why don't you go ahead and get started?
Well, good morning, Chairperson Henderson and members of the Health Committee. My name is Ruth Pollard, President and CEO of the DC Primary Care Association and Executive Director of the DC Connected Care Network. Thank you for the opportunity to provide testimony. In 2021, the National Academies released a report that stated primary care is the only healthcare component where an increased supply is associated with better population health and more equitable health outcomes. To achieve the primary care system district residents need, we must develop payment models to support team-based care, improve workforce shortage issues, build patient trust, and integrate social care into health systems. The Deputy Mayor and DHCF have opportunities across these key areas to make meaningful progress to increase and improve primary care. I will highlight 3. First, value-based contracting. DCPCA and DCCCN seek action from DHCF regarding value-based contracting requirements for the district's Medicaid managed care plans. Current VBC language should be strengthened and standardized to incentivize total cost of care models. This fosters successful implementation of value-based care programs and ultimately supports program effectiveness. Second, MCO oversight. Providers in the district must submit documents to at least 5 entities for Medicaid credentialing. DHCF should centralize and expedite this process to reduce provider burden. Our written testimony includes recommendation on third-party liability takebacks. DHCF can support provider-facing workforce and fiscal pressures. Third, maternal health. DCPCA congratulates DHCF for success in achieving a Transforming Maternal Health Award from CMS. This initiative aims to improve maternal care through financing and service delivery innovations. The Community Care Hub model offers a framework for implementing the 1115 waiver if approved. Multi-sector community-based approaches are essential for advancing maternal and community health. We need support for the perinatal workforce and ongoing investments in social care partnerships. Finally, the district may be at risk due to potential changes to its unique federal Medicaid assistance percentage FMAP formula. Congress may not understand DC's FMAP's origin, the purpose, and fairness. Applying the state FMAP formula would harm district finances. DCPCA will collaborate with the committee, council, mayor, district leaders, and health associations to protect DC's special FMAP. DCPCA and our health centers thank Deputy Mayor and DHCF Director Wayne Turnage and his team. We are committed to building a fair health system for all district residents and supporting the DC Council Committee on Health in this effort. Thank you.
Thank you. Richard? Oh, I don't see a Richard. Okay. What?
Woman, this is Zhenya. I'm one of the nurses from
Good
Mary Center.
morning.
So
Yes.
I will be Hewitt's interpreter, so she will be reading her testimony in Amharic, and then I'll read it in English, if that's okay with you.
That's fine.
So we'll need more than 3 minutes, though.
Yes.
Thank you. Hewitt, you can go ahead and read it.
Okay. Good morning, everyone. ዛሬ በፊትህ ለመናገር እድል ስለሰጠኸኝ እናመሰግናለን። ህይወት ውርጌሳ እባላለሁ። የዋርድ 4 ነዋሪና በማርያም ማዕከል የነርስ እና ቤተሰብ አጋርነት የቤት ጉብኝት ፕሮግራም ተሳታፊ ነኝ። በፕሮግራሙ ውስጥ ያለኝን ልምድ ለማካፈል እዚህ መጥቻለሁ። በፕሮግራሙ ውስጥ ለ2 ዓመታት ያህል ቆይቻለሁ። እርጉዝ ሳለሁ ጀምሮ አሁን የኔ ቆንጅዬ ልጅ የ16 ወር ሊሞላው ነው። በዚህ ጉዞ ውስጥ የኔ ነርስ የመኖሪያ ቤትን ከማግኘት ጀምሮ እስከ ሕክምና ጥያቄዎች መልስ በዲሲ ውስጥ ነገሮች እንዴት እንደሚሰሩ በመምራት እና ልጄን በጥሩ ሁኔታ እያደገ መሆኑን በማረጋገጥ ብዙ መንገዶች ረድታኛለች። ስለ ልጅ አስተዳደግ አስተምራኛለች። እናም እኔ መሆን የምችለው ምርጥ ወላጅ እንድሆን እውቀት እና በራስ መተማመን ሰጥታኛለች። የኔ ነርስ በቤቴ ወይም በሌሎች ቦታ ታገኘኛለች እና የስልክ ጉብኝቶችም አሉን። በጉብኝቶች መካከል ጥያቄ ባቀረብኩ ጊዜ መላክ ወይም ልደውልላት እችላለሁ። በስብሰባዎቻችን ወቅት ከኔ ጋር በመነጋገር የልጄን ክብደትና ቁመት በመመርመር እና በትክክል እያደገ መሆኑን በማረጋገጥ ጊዜ ታሳልፋለች። ሁሉንም ጥያቄዎች ትመልሳለች። ነገሮችን እንዴት እንደምሰራ ታሳየኛለች። እናም የምፈልገውን መረጃ እንዳገኝ ትረዳኛለች። እኔን የምትረዳኝ በጣም አስፈላጊው መንገድ በተለይ እንግሊዘኛ የመጀመሪያ ቋንቋዬ ስላልሆነ አገልግሎቶችን እንዲሄድ በመርዳት ነው። እሷ አንዳንድ ጊዜ ወደ ቀጠሮ ትሄዳለች ወይም ከእኔ ጋር ስልክ ትደውልልኛለች። ይህም አስፈላጊ ፕሮግራሞችን እንዳገኝ ቀላል አድርጎልኛል። ለእኔ እሷ እንደ ቤተሰብ ነች። ልጄ የራሷ እንደሆነች በጥልቅ እንደምታስብ ግልጽ ነው። በምፈልገው ነገር ሁሉ ትረዳኛለች። ምንም እንኳን በትክክል ምን መጠየቅ እንዳለብኝ ባላውቅም የኛ ጉብኝቶች በወላጅ ላይ ብቻ ሳይሆን በራስ ህይወት ውስጥ ድጋፍ ይሰጣል። የህክምና ቀጠሮችን እንደ ገንዘብ እንድገነዘብ አስተምራኛለች እና ለሁለታችንም እንክብካቤና የት እና መቼ እንደምፈልግ አረጋግጣለች። የቤት ጎበኚ በመኖሩ በማይታመን ሁኔታ ጠቃሚ ነው። ለምሳሌ ልጄ ሽፍታ ቢያጋጥመው ወይም ጤናማ ያልሆነ ስሜት ከታየኝ ሳያስፈልግ ወደ ሆስፒታል በፍጥነት መሄድ የለብኝም። ይልቁንስ ከሁሉ የተሻለ የእርምጃ አካሄድ ለመወሰን በመጀመሪያ እርሷ ጋር መነጋገር እችላለሁ። ይህ አይነቱ ድጋፍ በዋጋ ሊተመን አይችልም። በተለይ ለመጀመሪያ ጊዜ ወይም ነጠላ ወላጆች ለሆንን ለኛ ቤት ጉብኝት በማስረጃ ላይ የተመሰረተ ስልት ሲሆን ቤተሰቦችን በጣም ወሳኝ በሆኑ ዓመታት ውስጥ የሚረዳ እነዚህ ፕሮግራሞች ለወደፊት ወላጆችና ቤተሰቦች ትንንሽ ልጆች ደህንነት የተጠበቀ የተረጋጋ ቤተሰብ ለመፍጠር እና የወላጅነት ግቦችን ለማድረስ የሚያስፈልጋቸው መሳሪያዎች ይሰጣሉ። ምክር ለቤት ጉብኝት ፕሮግራሞች የሚያደርገውን ድጋፍና በከተማው ውስጥ ባሉ ቤተሰቦች ላይ ለውጥ ለሚያደርጉ ቁርጠኛ የቤት ጉብኝቶች አደንቃለሁ። አመሰግናለሁ። Thank you so much.
Thank you. Okay, I'll read the English version now. Good morning, Honorable Chair and members of the Department of Healthcare Finance Committee. Thank you for the opportunity to speak before you today. My name is Hiwat Orgesa, and I am a resident of Ward 4 and a participant in the Nurse Family Partnership Home Visiting Program at Mary Center. I'm here to share my experience in the program. I've been in the program for almost 2 years, starting when I was pregnant, and now my beautiful son is nearly 16 months old. Throughout this journey, my nurse has supported me in many ways, from finding housing resources to answering medical questions and guiding me through how things work in DC and ensuring my son is growing well. She has taught me about parenting and given me the knowledge and confidence to be the best parent I can be. My nurse meets with me at my home or other locations, and we also have phone visits. Between visits, I can text or call her whenever I have questions. During our meetings, she spends time talking with me, checking my son's weight and height, and ensuring he's developing properly. She answers all my questions, shows me how to do things, and helps me find information I need. One of the most important ways she supports me is by helping me navigate services, especially since English is not my first language. She sometimes accompanies me to appointments or makes phone calls with me, making it easier for me to access essential programs. To me, she is like family. It's clear she cares deeply about my child as if he were her own. She helps me with anything I need, even when I don't know exactly what to ask for. Our visits provide not just guidance in parenting, but also support in my own life. She's helped me understand medical appointments, taught me how to use an EpiPen for my child's allergy, and ensured I know where and when to seek care for both of us. Having a home visitor is incredibly valuable. For example, if my child develops a rash or seems unwell, I don't have to rush to the hospital unnecessarily. Instead, I can talk to my nurse first to determine the best course of action. This kind of support is invaluable, especially for first-time or single parents. Home visiting is an evidence-based strategy that helps families during their most critical years. These programs provide expectant parents and families with young children the tools that they need to create a safe, stable home and reach their parenting goals. I appreciate the Council's support for home visiting programs and ask that Medicaid reimbursement is fully funded and the dedicated home visitors who make a difference in the families like mine across the city. Thank you.
Thank you. Mr. Suwadi?
Thank you. Good morning, Chair Henderson, members of the committee. Thank you for the opportunity to testify this morning. My name is Usama Swati. I'm a partner at Gracker and Swati, one of the developers for the residences at Kenworth Park, the first assisted living community of its kind in Ward 7. Today, I testify not only as a provider, but also on behalf of countless partners who share a commitment to expanding access to affordable assisted living for the district seniors. Our partnership with DHCF, led by Deputy Mayor Wayne Turnage and Medicaid Director Melissa Bird, has been truly instrumental in bringing this much-needed model to Ward 7, ensuring that low-income seniors can access quality housing and supportive services without financial barriers. We've created a model for Medicaid assisted living without district development subsidies. I'll say more about this. Standing up this first of its kind program in Ward 7 was not only a significant challenge. However, through close collaboration with DHCF, DACL, and private sector partners, we successfully raised over $180 million in private capital, debt, and equity to develop the first two communities in Ward 7, the residences at Kenworth Park and the residences at Benny Metro, without requiring any development subsidies from the District of Columbia. This demonstrates how strong public-private collaboration can drive innovative solutions that improve health outcomes while remaining fiscally responsible. Expanding housing and workforce opportunities in the district. The residences at Kenworth Park now serves over 140 of Ward 7's most vulnerable seniors, ensuring that they receive care in a safe, supportive environment with high-quality housing and essential services. The residences at Benny Metro is a 156-apartment assisted living community, which will finish construction in May and begin receiving residents in July, with expected support from DHCF and DC Health. We look forward to having you at the grand opening. The residences at Georgia Avenue in Ward 7 is currently in pre-development and will begin construction at the end of this calendar year, further expanding access to Medicaid-eligible seniors. In addition to providing critical housing and care, each of these communities is creating over 90 permanent, well-paying jobs. We are proud to share that over 50 of our current employees at the residences at Kenworth Park are district residents living close to the community where they work. This not only strengthens our neighborhoods, but also provides stable career-building opportunities in the growing healthcare sector. Challenges and the need for this committee's support. Excuse me. While we have made significant progress, we must work together to improve the workforce development framework that supports this initiative. Specifically, we need improvement to workforce development programs, strengthening pathways for district residents to enter the healthcare workforce, particularly in assisted living and senior care roles. Licensure and reciprocity reform for healthcare workers. Many qualified workers face barriers due to restrictive licensure and reciprocity policies. We urge this committee to help streamline the licensure process for home health aides, certified nurse assistants, and other essential senior care professionals to ensure that we can hire and retain a skilled workforce without unnecessary bureaucratic delays. Regulatory updates to expand medication administration by certified medication aides. Current regulation require LPNs and RNs to administer medications, which can be costly and create staffing shortages. DC Health has finalized regulations in 2019 to allow certified medication aides to administer medications in assisted livings and other long-term care settings, but they never operationalized the program despite tremendous employer demand. Improved coordination with sister agencies to streamline approvals. While DHCF and DC Health have been excellent partners, we have experienced delays in obtaining approvals that have been costly to individual agency approvals at slow project timelines. We would appreciate the community's support in working with agencies to create more streamlined, predictable approval processes to ensuring this critical project can move forward without delays. Last but not least, as we continue to expand DEMPED and DCHFA, I know this committee doesn't oversee them, but in support may play a pivotal role in helping finance these projects and provide long-term sustainability. The leadership of Mayor Turnage and Director Bird have been pivotal, and we look forward to continued collaboration. And I appreciate the extra time. I'm sorry I went over.
Thank you. Mr. Drumming.
Good morning. My name is Joshua Drumming from the Washington Legal Clinic for the Homeless. A part of the city that suffers is the unhoused community. This is most visible amongst those also unsheltered and living in encampments. These are people who, likely because of deficits in DC's housing infrastructure, have chosen to live on the street rather than in a shelter. Instead of reducing factors that make shelters unappealing or increasing permanent housing resources, the Bowser administration has chosen to incessantly target DC's unsheltered. Last year, there were around 100 encampment clearings conducted by DOMHHS, efforts to displace unhoused people. Per the 2024 PIT count, homelessness in the district has increased by 14%, and unsheltered homelessness has increased by more than 8%. 2024's PIT count found almost 900 unsheltered adults in DC. Due to increasing homelessness, inadequate and/or unsafe shelter space, mass termination of FRSP, weakened eviction protections, and a harmful change to ERAP, the unsheltered population will likely grow. DOMHHS has been weaponized to erase proof of homelessness, targeting encampments and throwing away what is oftentimes every item an individual owns. Sometimes items hold sentimental value. Sometimes they are documents of legal importance. At the end of many DMHHS engagements, most are discarded, often in direct violation of the requirement to store non-trash items. Under Mayor Bowser, encampment evictions have become commonplace. In 2022, 70 people were evicted from the McPherson encampment. In 2024, DMHHS and MPS evicted 60 individuals from the Foggy Bottom encampment. DMHHS now plans to clear the Whitehurst encampment. Whitehurst was home to around 20 people, and despite postponements, the threat of eviction has already led some to flee the space. In the end, no matter how many people remain when DMHHS finally arrives, mass displacement will still have occurred. Encampment evictions generally must be accompanied by 14 days notice, but there is an exception: immediate dispositions. This protocol allows DMHHS to clear an encampment without notice as long as it presents immediate risk to public health and safety. Specifically, immediate dispositions do not require notice of the encampment site or on the DMHHS website. These immediate dispositions have increasingly been used as the preferred method of encampment clearings. Last year, over a third of evictions were immediate dispositions. Due to the lack of required notice, DMHHS can avoid coordination with outreach workers and observation by legal service providers that are present to ensure encamped residents' rights. Responding to immediate health and safety risk is important. However, DMHS misuses the health and safety risk language, using it against encampments that do not present such risk. Often, the immediate disposition qualification is used to remove a single unhoused person. It serves only as a tool to re-traumatize residents through uncertainty and dispossession. And due to its procedural holes, those victimized by this protocol cannot avail themselves of due process. Eliminating the visibility of homelessness does not eliminate homelessness. The solution to street homelessness is housing, not displacement. This committee and DC Council must provide greater oversight over DMHHS encampment evictions. Councils require regular reporting from DMHHS that includes data on the number of evictions and immediate dispositions, the eviction location, and the cost of each encampment eviction. DC Council must establish codified standards to govern immediate dispositions, implement greater guardrails for involuntary hospitalizations related to encampments, and conduct trash-only cleanings instead of full clearings. They must also improve the shelter system so that encampments don't seem like better alternatives, invest in housing resources, and endow the encampment space with the quiet dignity of due process of law. Thank you.
Thank you, Mr. Drumming. Commissioner Patel.
Good morning, Chairperson Henderson. Thank you for holding this hearing so that my comments may be entered for the record. My name is Trupti Patel, and I represent Single Member District 2A03, which is historic Foggy Bottom. I am the Chairperson Emeritus for ANC 2A, and I'm here to testify about two important issues that have impacted ANC 2A. Number one, encampment protocols and clearings. Number two, the Aston, DC's first high barrier homeless shelter that would primarily serve adults with acute medical conditions, mixed gendered adult families, and couples experiencing homelessness to stay together, populations that can't be properly served in any other shelters. My former colleague, Commissioner Yannicka Micton, authored an ANC resolution that raised concerns about how the Deputy Mayor of Health and Human Services conducted the clearing of the East Street encampment. In his resolution, he echoed a housing first policy as that clearing encampment with no actual plan on what to do with these residents isn't good policy. Advocates for years have been saying that this isn't problem solving. It's just passing it from one place to another place. This is not good use of my tax resources. It's smarter to have a plan on finding a permanent pathway to housing these individuals. In fact, numerous press articles have shown and discovered that many of these residents are housing voucher recipients just waiting to be placed in permanent housing. Clearing the encampments is traumatic for everyone involved, as the loss of crucial documents and the deepening the sense of mistrust with the government only makes it harder to believe we are trying to assist and help them, as we've just become the enemy. It is time for thoughtful and humane approach to invest in. The current method isn't sustainable, nor is it tenable. I challenge DMHHS to do better. In May of 2023, the George Washington University announced it had sold the Aston, a former graduate student dormitory located at 1129 New Hampshire Avenue Northwest, to the Washington, D.C. government through the Department of General Services for $27.5 million. At an ANC 2A June 2023 meeting, the Department of Human Services, along with DMHHS, sent representatives to address questions and concerns from the commission, as well as residents about services the Aston would provide. But the opponents of the Aston would weaponize the meeting and challenge the Aston through 4 different lawsuits, all of which have been withdrawn, stating that the city was not being straightforward. ANC2A at a special meeting in June 2023 sent a resolution in support of the Aston contingent upon certain conditions being met and outstanding questions around services provided and the state of the Aston answered. The reason for such scrutiny and intensity around the oversight by the commission is that the Aston was the issue that divided the commission and the community. And I, along with others on the ANC, wanted absolutely no errors on the implementation of the Aston. As a way to ensure that the community members had a way to engage in thoughtful and meaningful way, a community advisory team was formed to ensure that the Aston would succeed. The CATS co-chair, who is appointed by Mayor Bowser, is a top-level staffer from DMHHS, and it is due to her ability to be fair, honest, ethical, and transparent that has gotten the Aston to not only open and to succeed, but to break every single benchmark of success that has shut down the opposition and opponents to the Aston. DMHHS in this case got it right and right on the money. And when the right people are in the right places, they need to be the things that can operate smoothly. I am using this hearing as a way to hold DMHHS accountable and to inform them of how they can be better community partners and to address all stakeholders. Thank you, and I'm prepared to address questions to the best of my ability. Thank you.
Thank you, and thank you to this panel of witnesses for your testimony. Ms. Patel, I want to start with you. To what extent has the ANC heard anything about progress in terms of the Ashton?
Absolutely, and thank you for that question. And I'm sure Deputy Mayor Wayne Turnage may have more statistics than I do. So in the last Aston Cat meeting, which is publicly recorded, residents had asked about metrics of success. And as of right now, the Aston is pretty much at its current cap, which has been imposed by an agreement with Mayor Bowser and Councilwoman Pinto. So there are 49 residents. And so as residents are exiting out of the Aston to get into their housing situations, I do know that the statistics that has been shared is that 9 people did not stay in the program of the Aston for various reasons, what were not shared. But there have been no complaints from neighboring residents about the Aston. Everyone has the residents have given feedback to the staff saying that they are happy, they are content there. And the community residents such as myself are happy to have the Aston, and we view the residents as a part of our community.
Okay. We're going to ask some follow-up questions on that. And similarly, both you and Mr. Drumming provided testimony in terms of encampments. And I think that I don't know what's coming later this week from the White House, but I think it is going to call on all of us in terms of government as well as the advocacy community to have a better conversation about what our strategy is going forward around housing our unhoused, right? And I'm not even saying moving folks from one place to another, excuse me, but literally we're going to have to be more strategic in our conversations. And also, I think more realistic with residents around what they can and cannot do. And then also, what can happen today versus what can happen tomorrow. So I look forward to working with you all on that when we get there. Mr. Swati, I've been to the residence at Kenilworth Park. It is a beautiful facility. And at least the residents who I spoke to were all very grateful to have that as a space and opportunity for them. And we know that in long-term care, finding affordable places in the assisted living space in the District of Columbia, in folks' own communities, is very difficult. So the work that you all are doing there is excellent. Can you say more about your testimony in terms of strengthening pathways for workforce? the committee has done a lot of work to try to improve and streamline the licensure process for CNAs and home health aides. You know, pushing we tried to do the reciprocity agreement, but now we have a registration process where folks who are licensed in Maryland and Virginia, they just have to register in order to be able to work here. Are you, I'm trying to understand if you're saying that none of this is hitting in the way that it needs to, or if you're saying we just need way more people in this line of work than we currently have available to us right now.
It's thank you first of all for your kind words, Chairperson. I mean, it's we know the value. I mean, we couldn't have done it alone, but we know this is just the tip of the iceberg. As far as the specific question, I think it's all of the above. So we know, I mean, I've been working with Claudia Schlossberg for many years. I know a lot of the efforts that your committee and the bills that you passed recently primarily provide the framework, but we need more in the sense of supporting providers engaging, for instance, the UDC, engaging other folks that can help train and provide, because it's just the throughput. If you think about it, each one of these communities requires about 90 full-time equivalents,
Right.
50 of which are in direct care. CNAs will have several LPNs in each of the communities, and one of the big things is medtechs. Right now, I mean, I know the changes have taken place, but right now we're still required to use RNs or LPNs to administer medications to our residents, which is making it really difficult for us to be able to. There's only so many LPNs that are going to be around, and when you've got 157 residents or 156 residents, it makes it rather difficult because you don't have the right skill set delivering the service. So, and again, it's not saying this is a catastrophic risk. It's just saying that as we continue to stand this up, the workforce component is paramount to success because we want to maintain quality. And if you don't have the workforce, you can't deliver quality services.
Oh no, this is super helpful to understand, especially when I think about our overall shortage. Well, of course, the nurses union will say it's not a shortage. Nonetheless, I'm going to say shortage in terms of certainly the number of LPNs that we have registered here in the district. And then RNs who want to serve in that particular environment. I mean, I look at what's happening in sort of nursing schools. I have less people who are going to nursing schools, and I have a population of individuals who are aging and would desire to age in place or, in an assisted living facility. So this is super helpful to kind of understand. You said that the project on Benning Road will start accepting residents in July.
That's what we're scheduled to currently do, and I kind of hinted there that we will definitely need close collaboration with DHCF and DACL and DC Health and DHCF for our licensure to be able to open and provide services. We've got to get licensed as a provider in that community, as well as receive our Medicaid provider number. And we've been working with DHCF and DC Health very closely to make sure that licensing process doesn't take us. We'll finish construction in April, and we're scheduling about a couple of months and hoping that we will, fingers crossed, cross all the barriers and be able to take our first resident hopefully in July.
How many spaces are available at that location?
That's a 156 apartment community. If those are not familiar, it's directly north of the Benning Metro entrance, across from the Conway Center. And it's a mix of one bedrooms, larger studios, and what we call urban one bedrooms. So, but they're a total of 156 apartments.
Okay. All right. Thank you. We'll follow up on that. Like I said, we all have an interest in ensuring that these spaces are available to folks, and certainly, when we look at the layout of where we have assisted living facilities right now in the district, we don't have a lot east of the Anacostia River or in this particular community. So this is super helpful, and so any way we could be helpful, let us know. Ms. Orgadova, thank you for providing the translation for Ms. Orgesa? Orgesa. Okay. And sort of talking about home visiting, I think home visiting is super valuable. And, interestingly enough, something that Ms. Pollard mentioned in her testimony was just around how Department of Healthcare Finance recently got a grant award around maternal health model. And frankly, home visiting fits well into what they are trying to do there, or at least what they told CMS they will be doing. And so we'll be asking questions about the home visiting piece. We funded, as you know, we provided the full funding for the home visiting to be able to be eligible for Medicaid reimbursement. There seems to be not an ideological difference in terms of whether or not home visiting works or not, but there seems to be a turf war difference on one word, which is stopping healthcare finance from submitting the application. And so we're going to get into that further with them because, again, home visiting fits very well into the other things that they want to do on maternal health, and it is working and it is funded. So thank you for being here. Ms. Pollard, I wanted to ask you about a portion of your testimony around streamlining provider credentialing for MCOs. I've heard from, several smaller providers that this has been a really a challenge for them because you have to go through each of the various processes. You're submitting the documentation over and over again. Are there other jurisdictions who do this better?
Yeah, I think it's definitely a good question. We did take a look at some different models, and even our neighbor in Maryland does a better job in addressing the credentialing for Medicaid providers, or for those who provide services. So I think, yes, absolutely. And we're happy, I know, to share any of that information, but Maryland does a good job in that.
Okay. Is Maryland just is a one-stop shop type deal?
I think it is. I can always check in and circle back with you, but I know that they're one that we looked at when we made recommendations to DHCF on improving its credentialing process.
Okay. I'd love to hear more about that. All right. I don't have any other further questions for you all. If you can make sure to submit your written testimony for the record, you just go to the DC Council website, /hearings, and then you could just upload it right there. And that'd be great. So thank you so much.
Thank you.
All right. We're going to go on to the final panel for Deputy Mayor for Health and Human Services. So we have Commissioner Jamila White, ANC 8A, Commissioner Peter Wood from ANC 1C03, and Tanya Ridley for Time for Change. Again, you have to affirmatively accept our invitation to become a panelist to join us. Okay. All right. I see Commissioner White.
I need to switch devices. Can you call back on me? I need to just restart.
No problem. I'll go to Commissioner Wood first.
Me last. Okay.
Hi, my name is Peter Wood. You, council member, you alluded to some of what I'm going to get into, so I appreciate the thoughts. Let's go to it. I'm Peter Wood. Today I'm testifying on behalf of Single Member District 1C03 in Adams Morgan regarding the Office of the Deputy Mayor for Health and Human Services. I want to focus on a specific topic today: homeless encampments. Homelessness is not a new phenomenon in DC, nor is maltreatment of unhoused residents. But following last year's Supreme Court decision in Grants Pass versus Johnson, the need for bold leadership on this matter is, and I'm not trying to exaggerate, more urgent than it has ever been in our lifetimes. As we have painfully witnessed already, the cost of implementing right-wing homelessness policy is human lives, lots of them. And while I acknowledge there are likely many in DC government who believe they fight against those right-wing policies, when it comes to homeless encampments, the status quo is quite draconian. We need to change that together. While I strongly disagree with the Supreme Court decision in Grants Pass, it's important to acknowledge the situation at hand. The federal government refuses to protect its most vulnerable constituents, so local governments must step up to the challenge. In Washington, D.C., we are, of course, doubly tested, lacking statehood and enduring yet another round of attacks on the little autonomy we have via home rule. That is why it is essential that DMHHS, as well as partnering institutions, makes it abundantly clear where it stands on homeless encampments. No forced evictions, no surprise cleanups, no masquerading displacement as progress. Help relocate encampments as a last resort only with the consent of residents and a clearly communicated plan. I know together this is asking a lot. Yes, yet each of these objectives in itself is feasible. They just require some fortitude. I'd like also to see DMHHS staff more proactively engage with housed neighbors who try to criminalize homelessness, debunk their false claims, demonstrate how stable housing, if even in a tent, is a fundamental component of improving public safety. It is perhaps a common urban experience to see otherwise pleasant neighbors end up taking harmful positions against encampments because of fear. They see tents near the sidewalk and develop a fear of uncertainty. Unmanaged, that fear can become unhealthy or even violent. And rather than work collectively to get housing for people, that initially innocuous fear of volatility can transform into a hatred of the poor. I recognize that I'm speaking pretty abrasively, and I don't mean to generalize. There are well-intentioned individuals within DMHHS, and the deeper issue I'm emphasizing here is structural, but we need to restructure, and that starts with individual action. Frankly, without drastic change, I don't trust that DMHHS or the mayor's office more broadly will defend unhoused DC residents from the potential attacks on the horizon. When given the choice between defending an encampment resident's right to live versus a well-financed homeowner's perceived comfort, DMHHS has a poor track record. Please convert cynics like me so that we can concentrate our resources towards saving lives. We in Washington, D.C. have a choice: coddle an authoritarian White House and let them ruin the lives of unhoused Washingtonians, or serve residents regardless of how much real estate they've amassed. The District of Columbia is better than letting fear dictate our future. Let's prove it. Thank you.
Thank you, Commissioner. Commissioner White? Commissioner White, if you're speaking, you're on mute. I don't see Ms. Ridley. So Commissioner White, it's your time.
I'm sorry, my camera won't come on and my stupid internet kept going out. I'm trying to get on my cell phone to do it. I'm sorry.
It's okay. I mean, you don't have to be on camera. You can.
Okay. All
Yeah.
right. I was trying to get my cell phone because my computer keeps cutting off. All right. Thank you so much, Councilmember Henderson, for your leadership, commitment, and support in advancing health equity across the district, and particularly in Ward 8. You have really shown up over the last few years for our community. And of course, everyone, happy Black History Month. This is a time where we honor those who paved the way and recommit to the fight for Black freedom and prosperity. I am Jamila White, Commissioner for ANC 8A05 and Chair of ANC 8A, representing the Anacostia community. I'm coming to you with the issue that you're very familiar with, and I'm sure many people who've heard us talking throughout our community. We are facing a public health crisis, and right now, as most folks know, we're in an opioid crisis, and nowhere is this crisis more visible than Marionberry Avenue, Minnesota Avenue corridor, where roughly anywhere from 500 to 200 people gather daily who are in need of dire support. A couple of years ago, the Building Blocks program, which I'm not even sure if it exists anymore, identified that corridor as one of the most distressed areas in the city, as well as one of the areas that experience some of the highest rates of shootings and gun violence. This impact extends beyond addiction and substance use to all other types of needs not being met. Our community members, including students that attend Ketchum Elementary School, DC Prep, and Anacostia High School, and Kramer School, which all have to pass through this corridor, witness overdoses, public defecation, sexual assault, sexual harassment, and different types of violence and traumas daily. One of the drivers of the activity on this clinic is disinvestment, extreme poverty that comes with that, but also the BHD methadone clinic located at 1320 Marionberry Avenue. This is a treatment center that has been operating in our community for over 10 years and has not been a good community partner. In 2023, ANC 8A passed a resolution to the council and to the mayor's office asking for a relocation of this treatment clinic to a medical campus in Ward 8, so not outside of Ward 8, but a medical campus in Ward 8, where patients there can receive access to wraparound services and additional medical assistance that they're not getting at BHG. If you go out to the clinic, they open up at 5 in the morning, but the line starts at 3 in the morning. And the patients that need to receive those services have to wait in line for 2 hours outside before the clinic opens. And during that time, they experience a lot of what I think are human rights violations in terms of not having any access to the bathrooms. Other street drug sellers are trying to sell them drugs while they're sitting out there, and it's hard for them to even make it in the doors to get their services. We have asked for your support as well as the deputy mayor's support in finding a long-term solution to the clinic, and there has not been any progress. Also, Councilmember, I know I'm over time, but if you remember when you came to our ANC meeting in 2023, you came with Director Bazron, and at that time she committed to developing an 18-month public health and safety intervention plan for this corridor, along with helping to relocate the clinic and improve the clinic services. We followed up that meeting in early 2024 with the Deputy Mayor for Public Safety about our integrated plan. It is now February 2025, and we have not received an integrated plan at all. We have sent countless emails, requests for countless walks to both the Deputy Mayor for Public Safety, the Deputy Mayor for Health and Human Services, and the Director of Behavioral Health, asking for these interventions with no response and no action being moved. In addition, we have roughly 10, and with 2 more coming, substance use and behavioral use centers and clinics coming to our business district. And most of them do not do outreach to that 200-person population I talked to you about. They do not service the community that's actually living here in Ward 8, and many of the people they are servicing are coming from out of state, because this is starting to be, we are saturated with these businesses that are just here to provide services to people that don't live in our community to continue to collect money. We do understand the need, however, it's not actually serving our community. And so we call on you to really push the Deputy Mayor's Office for Health and Human Safety to fulfill their promises, to have a public safety intervention plan for our community, to do better oversight of some of the licenses for these businesses that are opening up that are not actually serving our immediate community and not reducing the harm that's happening, and then relocating the clinic. I will submit a full testimony once my computer starts. I had to do it from head because I couldn't open my testimony. So
No, thank you so much, Commissioner White, and thank you, Commissioner Wood, for your testimony. Commissioner White, I'll start with you. We've already had the hearing for the Department of Behavioral Health, and we're asking some pretty detailed questions around what is offered in terms of our continuum of care around substance use disorder. And unfortunately, there are just some pieces that are missing, whether it be partial programs, intensive case management. I'll be super transparent with you. I don't think that the Department of Behavioral Health has a plan, especially if the federal government substantially pulls back on its harm reduction federal grants, which is where much of the money that the district uses for harm reduction programs and outreach is coming from the federal side. And so this is definitely going to be an issue, but we'll certainly ask some of these questions about this, and we'll follow up about the integrated plan. I had forgotten that that was a promise, or excuse me, a commitment that DBH had made, but my staff will certainly follow up with them on that issue. And I appreciate you bringing it up here, because I often talk about how I feel like the Deputy Mayor for Health and Human Services is supposed to be doing this coordinated approach on a variety of different issues within the public health cluster. And unfortunately, sometimes there is very much a hands-off approach unless there is some immediate emergency and or crisis. Because this is definitely one of those things where we should be bringing together Department of Human Services, DBH, DC Health, and even Department of Buildings and otherwise to talk about where some of these locations are being cited to ensure that we don't have these very high concentrations of facilities just in one part of the city. So
And the quality of services too that they are providing. Like we're talking to the patients that receive them. But council member, I want to invite you to Anacostia and around 4 in the morning, 5 in the morning. I know that's really early. So you can like see what's happening firsthand and see just the inhumanity and the indignity that the patients who need these services have to experience. Like they're open defecating in line for hours on a medicine that makes them use the bathroom. Like it's just so inhumane. People are taking videos of them, putting them on the internet. And then that's let alone even if they make it, because while you're standing in line, it's people trying to sell to you. And sometimes you just don't make it in the building. And so it's a human rights crisis, in my opinion, and in our community's opinion. And we've been having meetings for years, and the ANC has like literally it's 20 people on the email, every council member, the OAG, the deputy mayor for health and human services, the deputy mayor for public safety, the chief of staff for the mayor's office, and we're coordinating all of this stuff, but we're just not getting that support from our government partners, and we're not moving. There's no action being made. And when the district spent $4 million last year to designate Anacostia as the arts and culture district, yet there's no investment into that arts and culture district, DCLP is just letting anyone who wants to get a license and say, I'm going to do some help on Marionberry get one. And I don't know where they're getting the funding from because they're not servicing this immediate community. And we know they're not because of the demographic of people they're serving. Like there are people who do not, there are white people smoking pipes and stuff outside of the treatment centers with Maryland tags, like going and getting in their cars. Like we know they're not servicing Ward 8, but it's hurting the community. It's hurting the 200 people that need that help and they don't get any outreach.
well, so let me say this, Commissioner White, because I don't want to vilify someone who is
No, I don't want to vilify and they need their help. But also,
being
if you're going to be in Anacostia, you need to serve the people that need you. It's 200
correct.
people in front of your door.
But what I am saying is that, you know, there are individuals sometimes who are in line very early for medicated assisted treatment because they are getting it before going to work. And
Yes.
there might be some questions in terms of dosage. I know that there will probably be other people who testify on the Health and Human Services front around are these individuals receiving the appropriate dosage so that you're not having this very symptoms of withdrawal at 4 o'clock in the morning and not able to make it to, you know, this next period of time. Now that's medical, right? That's not an outreach problem. That's a what is happening in terms of a diagnosis of a particular patient. But I just want to be very mindful of the language that we're using around someone who is doing these services, because they're seeking this support. And
Yeah,
so
I
we need to be
appreciate
able to
you
do that
correcting me.
in a better way.
Yeah, I appreciate you correcting me. I do want to say there's just a little slight difference. There's one outreach not being done to the 200 people who really, really need support. And that's where we ask for an integrated plan for that outreach for the clinics that exist that can't service them. Because we talked to those places and they said they don't have funding for outreach. They've told us this for a couple of years. They don't have funding for outreach. So something to address that outreach. But for the methadone clinic and particularly because that's the only treatment clinic, it's not run the way other treatment clinics are run across the city. They don't have appointment times where people can come in, so they're not having to wait for 2 hours and not having to be out in any type of weather conditions and be targets for 2 hours. The way that they operate is not serving the patients in the most humane way that they could operate. And we know this because there's other treatment centers across the district and they're operating differently. They're offering different treatment options that don't have the same side effects. They give people appointments, they offer them rides, they're making sure they have access to the bathroom, and they're making sure they have access to wraparound services and their needs are being met. That's not happening here. This is a clinic that's just seems like if you got insurance, you got some way to pay, we're just going to take you in and treat you like a dollar. We're treating you like a dollar. Each one of these patients are worth $1,000 to them every day. How many thousand? Like that's how it's being treated. It's not being a harm reduction. It's not being medical, getting your needs being taken care of. It's not doing community outreach. Let you get reintegrated. It's how much money can I make today?
Thank you, Commissioner White. Commissioner Wood, thank you so much for your testimony and for what you uplifted here. As I mentioned earlier, I have some questions and once we get to the government witness portion, particularly around encampments. When I look at the list of where encampments are, for instance, we have several encampments that are right next to or right behind a shelter, which is like, okay, so what is particularly wrong with those shelters that individuals feel more inclined to be in close proximity to it, but not go inside? Right. And so I think that is a question that needs to be answered. And I appreciate you raising it at again, the DMHHS level, because this is about a coordination piece, right? Shelters is a DHS function. What is their oversight in terms of their contractors? What is our function in terms of replacing some of these particularly like the single gendered shelters that frankly are past their lifespan? CCNV, for instance, kind of near the Judiciary Square, that was supposed to have been torn down and rebuilt years ago, and it still hasn't been. It is probably past its life cycle, and some of these other places as well. And so we'll definitely follow up on some of this. If there was a question that you wanted to ensure that the committee asked the deputy mayor, what would that be on this particular issue?
I mean, a lot. I mean, the main one's kind of broad, which is I've said this, I think I said it to Councilmember Mendelson on the politics hour recently, not about encampment specifically, but I mean, encampment specifically is this week, and the executive order is probably going to target from the White House. And I have constituents as well as neighbors and others in the city where I don't know what to tell them in terms of they're looking for leadership in the city to be able to feel safe with their local representation. And I want to know what the mayor's office of Health and Human Services can do so that I can kind of alleviate some of those doubts, because we're getting attacked from the White House. And if it feels like your local representation is kind of siding with that as well, I feel like there's not really anyone to trust in local government. I want to know how I can convince my constituents that that trust is something that's been earned.
All right. Well, thank you all so much. And Commissioner White in particular, can you make sure you submit your written testimony?
I do. I just have a question. I can send it to you after. We think there's a lot of opportunity the district could do in public, private, and philanthropic partnerships around some of this. It's just not being explored. So I'll just follow up with you.
All right. Thank you guys so much. We're going to go to now the public witnesses who are specifically signed up for the Department of Healthcare Finance. We're going to do panels of 6. Actually, we'll do panels of 7. 6 or 7, but we're going to do 7 for right now. So Commissioner Ashley Ruff, ANC 7F02, Jacqueline Bowens from the DC Hospital Association, Luz Viviana De Jesus from Bamboo Beginnings, Doula Services, Chris Gamble, Children's Law Center, Margaret Snow from DC Hunger Solutions, and Joseph Liu from the Capital Area Food Bank. We'll actually do 6. Again, need to affirmatively accept our invitation to become a panelist in order to join us on this panel. I'll give it just a minute. Okay, I don't see Commissioner Ruff, but I do see Ms. Bowens. So Ms. Bowens, when you're ready.
Thank you. Thank you very much, Chairperson Henderson. I'm like the previous panelists. I'm having a little bit, but I'm good now. I'll get started. Thank you, Chairperson Henderson and members of the committee. I'm Jackie Bowens, President and CEO of the DC Hospital Association. I very much appreciate the opportunity to present testimony this morning for the Department of Healthcare Finance's 2025 Oversight Performance Hearing. DC hospitals continue to enjoy a strong relationship with the Department of Healthcare Finance under the direction of Deputy Mayor Turnage and Medicaid Director Melissa Bird and the entire team. As hospitals in the district continue to experience high rates of occupancy and increasing utilization of the emergency room departments, we continue to be focused on increasing throughput. Ensuring that denials and unnecessary prior authorizations are limited is essential. The department has been an active partner, actively collaborating with hospital care coordination teams to facilitate the discharge of beneficiaries with complex needs. Equally important, it is critical that the department continue to work with frontline providers, including behavioral health, home health, and assisted living services, to ensure reimbursement rates reflect competitive wages needed to attract and retain staff. We certainly believe that this is another key way to address patient flow and throughput. And we know that this is incredibly challenging during this time of uncertainty around Medicaid. Our members are eagerly awaiting the approval of the hospital-directed payment program, and we deeply appreciate all the work of Angelique Martin, Joseph Brennan, and Eugene Simmons with their work on submitting the preprint. But while we're waiting, we will continue to build an infrastructure to help us in supporting the significant community investments that we are looking forward to participating. We're also grateful that the department has funded a study similarly for physician-directed payment programs, which we believe will also support increased access. And finally, I'd like to talk a little bit about some of the work that we're doing with the Perinatal Collaborative, along with Chris, DC, because this is clearly at the intersection of the great work that the department is doing relative to maternal health. We're pleased to report that we've had some great successes in increasing timely treatment of hypertension among pregnant women and postpartum people, moving from 35% to 85%. And we've also seen great work done with respect to social determinants of health. And we believe that this work will be even accelerated as a result of the recent award received by the department. And additionally, we are in the planning stages of doing some new work as it relates to maternal bundles in the hypertension space. I will stop there. I have additional comments that will be submitted to the record, and I'm happy to answer any questions that you may have.
Thank you, Jackie. Mr. Jesus?
Good morning. Can everyone hear me?
Yes.
Okay, thank you. My name is Luz Viviana de Jesus, and I am CEO and doula provider, CEO of Bamboo Beginnings Doula Services, and I am a sole. I hold the distinction of being the district's only Afro-Latina Medicaid credentialed certified business enterprise since 2021. I'm here today to formally submit our written testimony for the Committee on Health's February 12th performance oversight hearing for the Department of Healthcare Finance. We have submitted this testimony on the record, and I would truly encourage everyone who's still in this meeting to please look up the video that Bamboo Beginnings created and posted on LinkedIn that visually attests to what I'm about to say. And I want to thank ANC, Ms. Jamila White, I believe is her last name, for speaking about how some of these centers that are opened up are actually more harmful than good. Because according to DHCF, they're opening up a new community center for maternal care. And we all know that Black and Brown women die in hospitals. So opening up another center cannot replace doula care in the district and childbirth education. Bamboo Beginnings formally submits our complaint against the Department of Healthcare Finance and MedStar Family Choice. We allege that Wayne Turnage and his, by his own admission, illustrious team are failing in their oversight duties. According to Turnage's own testimony in fiscal year 23, the district MCO average fell short of meeting national benchmarks on measures relating to the effectiveness of care, access, and availability of services, preventative care utilization, and enrollee experience of care. This was according to his own testimony. His PIP, or performance improvement findings for maternal health, measuring birth and postpartum persons who received timely and postpartum care, on average, both prenatal and postpartum care rates declined from baseline, okay? Then their performance measure validation, which is a system that measures an information system capabilities assessment, determined that MCOs had appropriate systems in place to process accurate claims and encounters, which were then used to calculate performance measure rates. And according to his testimony, the MCOs received overall PMV ratings of 100%. We call this a blatant lie because we served the District of Columbia since 2020. And every single time our payments were late by AmeriHealth, who then canceled the contract in 2022 after serving them for 2 years when the district instituted the new slave wage rates. And then again in 2024, when MedStar forced us to work for 8 months without pay. I operate a solo LLC. Sole member LLC. I am a single mother here in the district. This is a resident-owned business. I jumped through every hoop and loophole to get through. I met every requirement to start my business, not only start my business, but then to become a certified business enterprise. Not just become a certified business enterprise, but then become a Medicaid credentialed provider, only to deal with incompetence, laziness, lack of telehealth skills, and a lack of oversight from DHCF. I'm not done. We challenge DHCF's findings, PMV, performance measure validation findings. As Bample Beginnings documented and reported, MedStar Family Choice Provider Portal failed to have requisite e-claim doula process for us to be able to access e-claims and be paid on time. Like I said, we worked for 8 months without pay. MedStar Family Choice, without a doubt, derailed our business, a certified business enterprise in the district, who has worked diligently to serve the population during COVID, I might add. They destroyed our finances. They got away with it because DHCF received a full report from us in August of 24 with 25 exhibits, 5 of which were MP4 files showing Carl Chapman screaming at me, yelling at me, berating me because I was seeking assistance from DHCF through Felicia Sears. All of this rhetoric about DHCF receiving funding and no improvements on maternal health care, according to his own testimony. Yet he made a $25.2 million profit for DHCF. So I call on you, Council Member and Chair Henderson, to investigate DHCF's all of these things that we are alleging. And if you want the full report, I'm happy to provide it to anyone here because I think that this entire process lacks transparency. I think that DHCF's vetting process for MCOs for awarding contracts lacks transparency. The providers are put through hell and back, yet these huge conglomerates of healthcare providers are allowed to operate in a smokescreen. I think that the Department of Healthcare Finance should have a repository where every time a provider lodges a complaint against a MCO, that it should be public so that we can all see what's happening here.
Ma'am, thank you so much. I let you go over, so you're now at 6 minutes. So if you just hold on, we've got other folks who have signed up to testify who also want to share some feedback on the performance of the Department of Healthcare Finance. Thank you.
Can I just please wrap up really quickly? I just want to say, under Wayne Turnage, he has not improved healthcare for the district's Medicaid population. He's been in his positions for 11 years. It's time for new blood in DC.
Thank you. Mr. Gamble?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Chris Gamble. I'm a behavioral health policy analyst at Children's Law Center, a Ward 5 resident, and a licensed professional counselor with experience providing behavioral health care to children, teens, and families in DC. Thank you for the opportunity today to testify about the performance of the Department of Healthcare Finance over the past year. It is DHCF's stated strategic priority to build a health system that provides whole person care, one that takes all dimensions of health into consideration. A key part of this strategy is to allow managed care organization plans to quote unquote see the behavioral health care their beneficiaries receive. This integration process, commonly known as a carve-in, has been paused since February 2024 due to financial constraints. My written testimony provides more details on what new practices the carve-in entails and background on how we arrived at this moment. But today I want to focus on the impact of the carve-in pause. There are approximately 220,000 people enrolled in MCOs who stand to benefit from the better communication amongst providers, shared quality standards, and ultimately improved health outcomes intended through the carve-in. The MCO's role in managing the care of their enrollees is made unnecessarily complex by the siloed system we currently have. The lack of system integration even contributes to higher healthcare costs due to higher rates of hospitalization and emergency room use. While we acknowledge the reality of needing funding to move the carve-in forward, we hope that DHCF uses the pause not as a waiting period, but as a time to make improvements in our healthcare system as preparation for an eventual carve-in. We have a few recommendations today for improvements DHCF can start with. First, continuing to add behavioral health providers to the CRISP DC Health Information Exchange can further strengthen data sharing and improve care coordination with physical health providers. We also ask that the committee work with DHCF to implement data sharing between DBH and the MCOs, such as aggregate outcome data that DBH already has. Lastly, we see the success in altering reimbursement structures for adult services like assertive community treatment as a model for changes that can be made with children's services like community-based intervention. Along with these changes, we ask that DHCF provide a new timeline for the carve-in and keep stakeholders informed about resuming this process. Thank you for the opportunity to testify today, and I welcome any questions the committee may have.
Thank you. Ms. Snow?
Good morning, Chairperson Henderson and committee members. Thank you for the opportunity to speak today. My name is Maggie Snow. I'm the Anti-Hunger Program Associate overseeing our SNAP work at DC Hunger Solutions. I'm also a DC resident. In my role, I provide direct support to DC residents experiencing hunger and use their feedback to inform my advocacy efforts. In FY24, our organization pre-screened over 1,400 residents and helped over 700 apply for SNAP. We thank the Department of Healthcare Finance for supporting District Direct, which residents rely on to submit initial applications and recertifications, upload verification documents, and check case statuses. All DC residents deserve access to a user-friendly, efficient, and accurate benefits portal. Today, I will share 4 recommendations that would make the portal more accessible: improvement to document requests, accuracy in translation, automatic generation of person reference numbers, and the addition of a progress bar to track application status. We urge DHCF to improve the accuracy of document requests in District Direct. Multiple times per day, I see cases where clients are asked to provide documents that don't apply to them. For example, non-eligible clients and mixed status families who apply for SNAP for an eligible family member being asked to provide immigration documents, or clients who live alone being asked to provide a border document. District residents should be able to navigate District Direct and trust that they're only being asked to provide necessary and appropriate documents. Second, we hope to see improvements to translation in District Direct. Residents who opt to receive all notices in another language sometimes receive notices that are only partially in English, only partially in their translated language, which is a language access issue. In FY23, DC reported a CAPER, or case and processing error rate, of 58.79%, meaning 58.79% of cases saw inaccurate denial, termination, or suspension. Partially or incorrectly translated notices in District Direct contribute to this rate. Clients work hard to accurately answer questions and provide their documents, and they deserve proper translation to make the process as easy as possible. My third recommendation is that District Direct automatically provide a person reference number, or PRN, when clients submit their application. This would allow clients who don't have a social to keep their account connected throughout the application process. Currently, clients without a social who apply for eligible family members have to call the service center and request a PRN that they can use to reconnect their District Direct account after application submission. This is an unnecessary barrier that can provoke fear and confusion. If clients were automatically provided with a PRN, they wouldn't have to call the call center and could more easily track the status of their pending case. Finally, it would be beneficial to add a tool that allows residents to track the status of their application. Often, documents are left waiting for approval for months. A progress bar could note when these documents were reviewed by agency staff and remind residents to complete necessary steps like the SNAP interview. These recommendations are directly informed by my daily interactions with clients who rely on District Direct for benefits processing. I urge the committee to consider these recommendations to further support residents who use District Direct to apply for vital food and medical assistance. Thank you so much.
Thank you. Mr. Liu?
Chairperson Henderson, members of the committee, my name is Joe Liu, and I'm Director of Advocacy and Public Policy at the Capital Area Food Bank. The food bank's the anchor of the hunger relief infrastructure in our nation's capital, providing over 60 million meals to people in the district and the region as a whole. We work with a network of nearly 200 other community-based organizations here in DC to provide assistance to our neighbors. We wanted to take this opportunity to commend the department's 1115 waiver application and collaborative approach to program design. From our perspective, the addition of nutrition services to Medicaid is key. According to our latest hunger report, 38% of district residents are food insecure, including 15,000 children. The waiver is an opportunity to address the harmful consequences of not having enough food on health outcomes and expenditures. The Capital Area Food Bank is one of the leaders in the region's food as medicine efforts. We serve over 4,000 patients with nutrition-related health conditions using food pharmacies, grocery deliveries, produce boxes, and other nutrition supports. In partnership with providers like Children's National and Unity Healthcare, we identify and target both children and seniors whose food insecurity hurts their health. We're testing whether carefully choosing the right patients and providing them with the right foods can improve health and reduce costs. We agree with the department that the waiver has to be tightly targeted to health conditions whose outcomes could be most improved by nutrition supports and services. Much as we'd like to, Medicaid is not a financing mechanism to solve food insecurity. If this waiver is to succeed, how do we choose the right patients and which nutrition services are most appropriate? The department has taken a really exemplary approach to answer this critical question. For the past several months, they've gathered community representatives, current and potential providers, managed care organizations, and healthcare advocates to monthly and regular program design meetings. It has been a true collaborative in many ways. The food bank looks forward to continuing working with the department on the 1115 waiver over the next year. It's a tremendous opportunity to improve the health of some of the district's most vulnerable populations. And we hope our positive feedback on the department's efforts in this arena are helpful and constructive to the council as you perform your oversight duties and consider the FY26 budget. Thank you.
Thank you. And thank you to this panel of witnesses for your testimony and for the work that you all do. I'm going to start on the food, because you guys were the last to testify, both from DC Hunger Solutions and the Capital Area Food Bank. Mr. Liu, when I see your trucks around the city, it is often a strong reminder of the work that you all are doing, because they're not small trucks. They they are large 18-wheeler and beyond. I'm curious if you all have heard anything from Department of Healthcare Finance about the status of the 1115 waiver.
Well, it was hard for them to finish up before the end of the last administration. My source of optimism is that the early food as medicine 1115 waivers were all approved during the first Trump administration. And much of the language from the nominee for RFK Jr. to HHS has been about how food is so critical to healthcare. So we hope that there are opportunities to continue the conversation and deliver both better food security and reduce healthcare costs and better outcomes. We've got a few months. The waiver was extended till June so that the current activities could continue and give the new administration time to show up at CMS and start work on these things. So we maintain our optimism and our hope, but we also want to point out important legislation like Council Bill 24 that would really make it much easier for the managed care organizations to add nutritional supports into their contracts and into their service offerings.
Yeah. Yep. Okay. Thank you for that. Ms. Snow, thanks for the recommendations in terms of improving the benefit application. This committee has held several hearings on the DC, well, it's known as the DC Comprehensive Access System, or DC CAS, which is in some ways joint between Department of Healthcare Finance as well as the Department of Human Services. And so I'm sure you've heard my rant about the fact that we have spent 3 baseball stadiums worth of money on this system, and it still does not work the way that it is intended to do so. I have been trying. I feel like any application, whether it be for SNAP, whether it be for health licensure, whether it be for a license with the DLCP, should have a progress bar on the application so that folks can track their progress, as opposed to feeling like they are submitting documentation to a black hole. I wanted to ask you, though, you said that you had been working specifically with constituents to help them apply. Have you noticed any improvement in the application processing time?
I would say thank you for that question. I would say it depends on the case. We are still seeing cases where clients, in regular cases, non-expedited, are waiting longer than 30 days for a response. We're grateful. We work closely with the DPO team at DHS to resolve those cases and get a timely response. But we are still seeing cases that are going over 30 days for regular time, or 7 days for expedited cases.
Okay. All right. I'm now on the Committee on Human Services, so I have an opportunity to follow up directly with Interim Director Pierre on that and kind of see where that is. But I also plan to ask questions of Director Turnage with his deputy mayor hat on, in terms of because it's not just a delay in SNAP processing. It's also been a delay in Medicaid applications as well, because it's all through the same system. And so we need to talk a little bit more about that. Ms. DeJesus and Mr. Gamble, thank you so much for your testimony. Mr. Gamble, I have questions about the delay in terms of the carve-in, particularly how it has impacted the ability of the Department of Behavioral Health to do some of the functions that they thought that Medicaid managed care organizations were going to be doing, and now they're not doing because that was delayed. So, I think some of your recommendations around like going ahead and adding these providers to CRISP and doing some of these other things would be helpful. But I think the biggest question that was also raised during the Department of Behavioral Health public witness hearing was around like, there's been no communication on what's the timeline. Is this just paused indefinitely? And if so, then we need to have conversations about how we build back in those things that were sort of taken away. Is that sort of your feeling as well?
Yes, I think even again, we acknowledging what the barriers are, even having a timeline of, if the money were available today, how much time would it take to complete this process of the carve-in? I think stopping the public communication kind of leaves stakeholders in the dark about, is this something we're giving up on? Is this something we're just waiting for the money? Like what? So yeah, a new timeline is something that we would like to see communicated.
Okay. We also have some very specific questions around the maternal health and doula services and payment pieces and oversight as well. So I appreciate the testimony that you've provided, and we'll certainly follow up with Director Turnage and his team. Ms. Bowens,
Sorry, Council Member. Does anyone on the panel I would love to receive some questions. I really would love to have a dialogue. I've waited over a year to have this opportunity to meet with the Committee on Health, and I submitted this report in a timely fashion to DHCF on early August. And so at this point, I really would hope that somebody on the panel has a question for me.
So I'm the only council member who's here. My other colleagues who haven't had an opportunity to meet with you or to meet with the other to review your documents aren't here at this time. You and I have met, you've met with my staff multiple times. I think some of the questions that you have are questions for healthcare finance that we want to get out. And so, you know, originally, if this hearing, if we hadn't had, you know, 5 inches of snow, we would be having those conversations with Director Turnage this afternoon. But we're going to do that at a later date. So Ms. Bowens, I did have a question for you to follow up about with regard to ongoing discussions with Department of Healthcare Finance about the hospital directed payment plans. You know, we had a long conversation about this during the budget process, and I know that the documents were submitted, but I'm curious whether or not, you know, how are we feeling about whether or not this is going to get approved and what happens next?
Well, thank you, Chairman Henderson, for the question. So we are in almost daily contact with the department and working together with them and our other partners around making sure that we are submitting our information timely. You know, we are hearing on the other side from the federal side and my colleagues across the country because there are about 20 states that also have their applications in. And so, you know, we are hopeful that the good news is that we've not gotten any major questions that have raised concerns about our model, about our overall plan. And again, I think it's, you know, the transition is something that's certainly holding things up. And it's our understanding that they want to get a few more people in place. But, you know, staying cautiously optimistic. And it's been just again, an ongoing engagement with the department. But in the meantime, we're still kind of setting up things with respect to kind of ensuring that we have the infrastructure on the community reinvestment piece and kind of continue our work in that regard and remaining cautiously optimistic.
Okay. I mean, I think the fact that we are one of other, what, 20
Exactly.
other jurisdictions,
Yes.
in a similar vein as what Mr. Liu was talking about in terms of the food as medicine,
Yes.
right? We're not pioneering.
Yeah.
We are,
And there are and I will say, and there are multiple colors of states too, and that's also a good thing.
yes. And as we sort of talk about some of these things, obviously, I'm and we could talk about this more offline, Ms. Bowens, but I'm hopeful that the hospitals, especially those that are in larger networks, are having conversations with their allies and friends on the Hill about our FMAP situation, which would hit hospitals
Yes,
hard.
let me just say that we have we are being aggressive in that respect. State, local, regional. We've had multiple meetings, both locally with the department. We had a great conversation with the administration earlier this week. We are working with our national, and we've also put together a coalition of associations. So I would be happy to talk to you offline about our overall strategy with respect to some of the proposals that we're hearing about and also can do some updates on some of the activities that I'm working on with respect to on a national side. So
Okay.
happy to discuss that with you.
Great. Thank you so much. And, you know, on the work that you all have done with the Perinatal Quality Collaborative, I'm gonna just keep trying to give you the support that you need.
And we thank you. We thank you. I was trying to be very respectful of my 3 minutes, so I have a lot more to say, but I was trying to be a very good girl today.
I appreciate that. Okay. We've got several other folks to go. I don't have any other further questions. Thank you all for being here. We're going to move on to the next panel. Veronica Sharp from the Healthcare Association, Fernanda Ruiz, who's the Director of Home Visiting for Mary Center, Jennifer Vega from Mary Center. I'm not sure if she's coming back. We've got a crew from Mary Center here. Magli Chalk from Mary Center. Deja Williams from Spaces in Action. And Jaren Hill Lockridge from Dreaming Out Loud. Again, folks need to affirmatively accept our invitation to become a panelist. Okay. Well, we've got some folks who may have thought we were taking a snow day, but we're gonna work through it. Ms. Ruiz?
Thank you. Good morning, Chairwoman Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Fernanda Ruiz, and I'm the Home Visiting Director at Mary Center, a member of Under 3DC, and a district resident from Ward 4. I am here today to provide testimony regarding Mary Center's partnership with DC Healthcare Finance to implement the Nurse Family Partnership Program and the sustainability of the program. We were disheartened and confused to see DHCF's performance oversight responses, where they stated DHCF does not intend to submit a state plan amendment for Medicare reimbursement of home visiting programs to implement the provisions of the fiscal year 25 Budget Support Act. Let me explain our confusion. DHCF continues to show support and investment in home visiting as an effective strategy to improve maternal child health outcomes, including the following actions. DHCF applied for and was one of the selected grantees for the Center for Medicaid and Medicaid Transforming Mental Health model. The TIMA model included home visiting. Our experience working with DHCF as a grantee has been one of collaboration and shared commitment to district birthing persons and their babies. Just last month, we signed an agreement for $325,000 for fiscal year 25 to continue implementing NFP. As reported by DHCF on their performance oversight responses, NFP has incredible program outcomes. Yet, DHCF intends to not submit the SPA to reimburse nurse-led home visiting services to Medicaid. The SPA is a smart, effective way to leverage federal dollars to support NFP in the district. Without Medicare reimbursement, NFP will not have enough money to continue operations despite our best efforts to both raise funds and partner with the council and district government to get the bill passed and funded. Therefore, we are left confused. The HCF recognizes the value of NFP and is willing to let the program shut down by not investing in long-term sustainability strategies, such as leveraging Medicaid at this time. The HCF is willing to leave families without the support of NFP and at the same time delve into their TIMA grant to improve maternal and child health outcomes. Starting a new program from scratch in a few years when DHCF begins implementing their TIMA grant will come at a higher cost. On this note, we urge DHCF to reconsider their position on the SPA and continue partnering with us in implementing NFP in the district. We hope we can build from here to continue our shared commitment to serve families in the district with the goal of improving maternal and child health outcomes. Let's recognize the importance of maintaining investment in our programs within our system of care towards safe and healthy families that lead to safe and healthy communities. Thank you for the opportunity to testify today, and I'm happy to take any questions.
Thank you, Ms. Ruiz. All right, I don't see Ms. Vega with the rest of the team from Mary Center. Are you the only one testifying today?
No, I believe we have more folks. It might be listed as Abby Goldstein,
Okay.
representing Jen Vega.
Okay, hold on. We'll promote. You said Abby Goldstein?
Correct.
Okay,
And
so while those folks,
and Jenia, sorry, my apologies, council member. And Jenia Ovordova is also providing testimony. She provided the translation earlier, but she's also providing her own testimony.
okay. Ashley Evgenia Ordova, her as well. Okay.
Thank you.
So who is presenting testimony for Jennifer Vega, or is that somebody else?
That's
Hello,
Abby Goldstein.
Abby Goldstein, and I am presenting testimony for Jennifer Vega.
Okay, there we go. All right.
Proceed. Thank you so much. Dear council member, I'm writing to urge the council to allocate increased funding for the Nurse Family Partnership Program in Washington, D.C. As a former nurse in this critical program, I've witnessed firsthand the life-changing impact NFP has on vulnerable first-time mothers and their children. However, the program is severely underfunded, leading to unacceptably low salaries for the dedicated nurses who provide these essential services. salaries that do not even meet the average pay of other nurses in DC. Due to the unsustainable salary structure and chronic underfunding, I was forced to leave my position, despite my deep commitment to serving families in need. This personal experience underscores the urgent need for better funding to retain experienced professionals and ensure that quality care is not compromised. NFP is an evidence-based program that improves maternal and child health outcomes, reduces preterm births, increases economic self-sufficiency, and lowers the rates of child abuse and neglect. The nurses who commit to this work do so out of passion and dedication. Yet without fair compensation, the program struggles to retain these professionals, which ultimately jeopardizes the quality of care provided to DC's most vulnerable families. I respectfully request that you advocate for increased financial support for NFP in the upcoming budget discussions. I trust that your leadership will help secure a sustainable future for this program, ensuring that both our community and its healthcare professionals receive the support they deserve. Thank you for your time and consideration.
Thank you, Ms. Goldstein, for reading that testimony. Ms. Orgadova?
You again for for speaking the second time. Right, so to Chairperson Henderson and the members of Healthcare Finance Committee, thanks for the opportunity to testify in support of the Medicaid reimbursement for home visiting services. My name is Zhenya. I use she/her pronouns, and I'm a nurse home visitor with the Nurse Family Partnership of DC at Mary Center. Sounds like I don't really need to convince you that home visiting services work. A lot of people have spoken, and I've spoken at various different hearings in the past. And we know that they provide essential prenatal care, postnatal care, parenting education, early childhood intervention, all proven strategies to improve health outcomes, reduce infant mortality, and break cycles of poverty, help strengthen families. NFP has been shown to generate nearly $6 for every $1 investment, which is a significant decrease to the healthcare operations of Medicaid covered families. It also significantly decreases costly complications, emergency room visits, and hospitalizations while delivering long-term savings and social on healthcare and social services. But I think today I'm here with more of a plea. Right now, as political uncertainty threatens critical social programs, and services and protections for the most vulnerable are being dismantled, the need for these services has been even more urgent. And now more than ever, we really must build sustainability and increase access for the programs that directly address the very injustices and the very problems and everyone who is under attack. Home visiting programs are truly a lifeline for our city's most vulnerable mothers, children, and families. I do this work because I believe in it with every fiber of my being. I see its impact every day, and like so many professions that are largely supported by women, nursing, teaching, caregiving, it's often dismissed as like a passion profession. And we do have passion, but passion alone does not replace the need for fair wages, resources, long-term stability so that we can support our own families while working to support the families in our community. Women disproportionately do this work. It's underpaid, undervalued, while simultaneously serving those even more underserved, underpaid, and disproportionately harmed by systemic inequities. And make no mistake, the people we serve, women, birthing parents, children, families, they are under attack. It's never been more critical to protect them. It has never been more critical to protect us, the workforce that shows up day in, day out, and do this essential work. Sustainable funding creates sustainable programs. Sustainable programs become lifelines within our communities, supporting generations to come. And now is the time to build that sustainability, because without it, we risk losing not just programs, but people and families and futures. As DC continues to champion racial justice and health equity, implementing Medicaid reimbursement is not just the right thing to do, it's critically necessary for services like NFP. The council has the power to act and the funds have already been allocated. I urge you to protect and expand access to home visiting services by submitting a state plan amendment for Medicaid reimbursement of home visiting programs to implement the provisions of the FY25 Budget Support Act. Our city's families are counting on you and we are counting on you. Thank you. Sorry, I went over time.
No, thank you. Okay. Is someone reading the testimony for Magalay Shock? Right. Okay. Gonna go to Deja. Good to see you.
Nice to see you too. Good morning, Chairperson Henderson. My name is Deja Williams. As you know, I'm a ward for DC Native and Health Equity Organizer with Spaces in Action. Spaces in Action, we also a member of the DC Coalition and a part of the Mary Center Community Advisory Board. My testimony today will focus on the urgent need for Department of Healthcare Finance to submit a state plan amendment for DC to receive Medicaid reimbursement for the Nurse Family Partnership Program. To not bore you with some of the detail that you already know about the process, I want to get into some of the numbers that talk to the success of this program. So in 2024, NFP served 103 families, 74 infants, and completed 904 home visits. Families are supported by improving parental health outcomes, promoting the parent-child relationships, and enhancing child development. Specifically, NFP targets negative outcomes with strategies such as clinical assessments, individualized goal setting, educational materials, and self-advocacy skill building. NFP is directly addressing DC's perinatal and infant health outcomes, which are among the lowest in the nation. In 2023, 98% of NFP participants took prenatal vitamins, 84% attending all recommended prenatal visits, 94% received prenatal mental health screenings, and 0% of the babies were very low birth weight. 99% had a medical home, and 71% used safe sleep practices. 99% engaged in breastfeeding, and 100% of children received up-to-date immunizations at 6 months. As you can see, the program works. If the state plan amendment is not submitted, this program will be shut down and not be able to continue past the fiscal year 2025. This will not only negatively impact the home visitors that are directly employed under this program, but also new parents that can join this program and existing participants. So we know that you support this program, Chairperson Henderson. We're asking and urging that the Department of Healthcare Finance please submit a state plan amendment. As mentioned before, our babies and our families in DC are depending on it. And I yield the rest of my time and I hold any questions at the end. Thank you.
Thanks, Deja. Jaren?
Okay, there I am. Hello, Chairperson Henderson, and thank you for the opportunity to testify today before you all about the DC Healthcare Finance. I'm Jaren Hill Lockridge, a Ward 8 resident, and I am speaking in my capacity as the Director of Strategic Partnerships for Dreaming Out Loud, a community-based organization committed to advancing health equity and improving nutritious food here in the district. We want to commend DCHF for their role in understanding the social determinants of health, and I want to specifically speak about the 1115 waiver and the need to include food services to address food insecurity, which you know is a major driver of health disparities here in the city. This strategy is an important step toward ensuring that Medicaid beneficiaries will receive the comprehensive support that considers the physical, mental, and emotional well-being. We understand the urgency around food insecurity because 36% of residents, as you know, are food insecure, and a large portion of that is disproportionately Black, African American, and Latino communities. We know that food insecurity increases the likelihood of chronic diseases such as diabetes, hypertension, and obesity, which are all prevalent in the district, especially in Wards 7 and 8. Furthermore, food insecurity costs the district hundreds of millions of dollars in direct healthcare expenses, underscoring the need for a proactive, systemic approach to nutrition support. To maximize the impact of this waiver and to ensure it effectively addresses the needs of DC residents, we have some recommendations around expanding nutrition services, refining the eligibility criteria, as well as investing in infrastructure to support nutrition services, from workforce development to train our communities, as well as outreach and education. So as the Department of Healthcare Finance works to integrate health-related social needs into the Medicaid system, we really urge the agency to prioritize relationships with community-rooted organizations such as ours. Our organizations play a critical role in ensuring that the health-related social needs interventions are culturally appropriate, accessible, and sustainable. We appreciate your leadership and the agency's leadership in this space to improve health outcomes for all residents. And again, thank you for your time and consideration, and happy to answer any questions.
Thank you. Thank you to all of this panel of witnesses. I'm going to start with you, Ms. Lockridge, because I think everybody else on this panel talked about home visiting. And so I'm not sure if you were listening to the previous panel, but we had the conversation with Capital Area Food Bank and DC Hunger Solutions around the 1115 waiver and the Food as Medicine initiative. And I think what you raised in your testimony is exactly right. Frankly, I could give you all the health insurance in the world, but if you're not consuming healthy and a balanced meal and products, it's not going to matter in terms of truly tackling some of the chronic healthcare conditions that we have, that are a lot of which are food-based, like diabetes, which is a really big issue in the community. I'm curious, and I want to give you the opportunity to talk a little bit more about Dreaming Out Loud's new physical initiative that is coming, and talk about the timeline in terms of when you guys are going to be opening your doors.
Thank you for the opportunity and the question. We're really excited for Dreaming Out Loud's new headquarters, the Marion Berry Avenue Market, to do amazing work at the intersection of food and health related work. We could talk all day about, Cedar Hill and the things that are happening within those walls. But if you talk to leadership, you understand that when you look at the entire comprehensive healthcare landscape, 20% happens within the walls and the other 80% happens in community. And we are a very clear response to that other 80% that happens in community, making sure that folks, when they come home, are able to eat. We're really in that food as medicine space at that intersection, making sure that our community understands that what goes into your body directly affects your health and well-being. It's very expensive to eat healthy, and it's also very expensive to be poor, right? And so how do we combine those two? And we're really trying to do something unique here in Ward 8 to help change the healthcare ecosystem and the food ecosystem by bridging the two together, using our trusted subject matter experts and resourcing the people who are already doing the work right here in community.
Yeah, I think that for a lot of folks don't necessarily think about the cost of food in terms of healthy versus versus not, but a bag of granola will cost you $7.99. A box of Fruit Loops, no shade to the Fruit Loops eaters out there, but it's a very different product, is going to cost you, $3.99. And so, even a salad being $14.99 going up against a value meal, we have to have these sort of conversations in terms of how we kind of help folks on that. But thank you for that. And my bad, I should have asked Chris Bradshaw to to join you on this panel. I didn't see him right after you, but we'll get to Chris's testimony on the next one. I do want to turn to the team for Mary Center as well as Spaces in Action. Ms. Ruiz, if you're still with us, you referenced what was in the testimony, or sorry, the pre-hearing questions from Department of Healthcare Finance. I'm curious if you all have had any conversations with the Department of Healthcare Finance and what they have told you about the continuation of either home visiting or the nurse family partnership, considering that they are deciding to hold the money and the spa hostage.
Hi, thank you, Council Member. We do meet on a monthly basis with DC Healthcare Finance. And as I mentioned in the testimony, in those meetings, we see collaboration, we see interest, we see genuine curiosity for the program, the outcomes, interest even in participating in home visits, as well as team meetings to get to know the team. They have shared their plans about the team and how they're beginning to outreach to the community and stakeholders, which I think is really important work that they're doing. However, when we talk about the SPA or the Medicare reimbursement, there hasn't been any update around it. They haven't been able to provide me with any updates. So that conversation is not very ongoing.
So we're
when we
having
meet.
conversations about reaching out to partnerships, but no conversations about how we fund this program in the future, should they elect not to seek Medicaid reimbursement.
Correct. We have expressed our concern that at this point in time, for example, we have 2 vacancies in the program from nurses that have turnover. And we have decided as an agency to not backfill these positions because we want to be fair to our staff. And our commitment is to the staff that we currently have. And we don't want to bring 2 people on board when we don't know we're going to have a program at the end of the year. Correct?
Yep.
And so they are aware of these decisions that we're making, and they seem understanding, but there's no conversation around the Medicare reimbursement.
Okay. I want to be very clear for the public.
Mhm.
This is paid for. We have paid for it through the financial plan on the local side. We have an agency that is refusing to follow the law because of a disagreement over one word, may versus shall. Again, not an ideological difference. They clearly are not saying they don't like home visiting. They are just choosing to exercise a level of petty power that is really disappointing, especially given all the other issues that we have going on in public health right now. And so I'm going to keep saying, and I'm sure my colleagues will say as well, the council did their part here. We have funded this program. And so if home visiting ends in the District of Columbia and the Nurse Family Partnership does not continue into next fiscal year, that is on the administration. That is not on the council. But thank you so much for being here and for the work that you're doing. Deja, I'm curious, are you having conversations with some of your clients about whether or not this is going to continue? I can ask the same for Ms. Orgadova. I mean, this is an important piece, to the work that we're doing to connect families to care and community.
Yeah, a lot of what I know is through Fernanda and through our policy folks at under 3DC about the conversation they're having with DHEF. I have just, been telling folks in community from what I hear and just being as transparent as I possibly can. But
right. But I'm talking about the feedback that you're getting from folks in community when you tell them that we might not be able to continue.
Not good, but I think the question has been having the question I have is, so like, what if there's any support from council, what support can we have, or how can we move forward? Has been the overarching question that I don't really have an answer to, that I was hoping that we would together. But yeah, that's really all I'm hearing, is a lot of uncertainty, and so like what's next.
Yep. Ms. Orgadova.
Yeah, thank you for that question. I think right now is really difficult because there are so many things that people are really afraid about and of. And so the possibility, I will tell you, like, our participants are disappointed when they have to graduate our program and they're doing well, right? They're doing well. They don't really need us anymore. And they are disappointed to not have us in their back pocket, and some people have done like so much growth in the 2.5 years that it's wonderful to see. And for some people, we know they will continue to need services. But I mean, to me, even like, it's devastating to think that we would have to discontinue a program like ours. Like, I've been dreaming about this program for years before it even started in DC. It is the value and the impact of what it does is it's honestly difficult to describe, right? Like, it helps people feel good about themselves. They want to plan, they want to dream, they want to have a better life, they're better parents. There's so many times we hear, you're the first person to tell me that I'm a good parent. You're the first person to tell me that I'm allowed to have my own goals, my own dreams. And I know we're not like reaching every single person in the city, and I wish we could. I wish every mom, every first-time parent could have someone to support them. But especially those who are already enrolled and may not be even anywhere close to graduation, they're really concerned about potentially losing us and, amongst us, probably other services.
Yeah, it's
That's
sort of
really
like
challenging.
the 1-2 punch of, uncertainty in other areas, and then in this space
Right.
as well. And I want to just lift up something that you talked about oftentimes when we have conversations about maternal health, everybody focuses on the first 3 trimesters, but the 4th trimester is actually probably one of the most important pieces for both the parent and for the infant, because that's where, it's everybody threw you a baby shower, but nobody's there to help you on the back end, in terms of meals and making sure that mom could take a shower and checking in on the perinatal, checking in on the mental health of the parent. And having a child does not come with a owner's manual. And so the support that we're able to provide people beyond just a car seat is helpful and informative. And so you all have my commitment. We're going to keep pushing on this because, like I said, we paid for this program already. Okay.
Thank you very much. We so appreciate all of your support and the work that you've been doing for it. Thank you.
Yes, thank you so much for that commitment to continue this fight, because it is a unnecessary, I think, fight.
Unnecessary being the the key word. Okay, I don't have any further questions for this panel. I'm gonna try to keep it moving.
And on if
Ms.
that's-
Goldstein.
This is for Jennifer Vega, who can't be here. You asked about how our clients feel with the potential for the program ending. And I wanted to add in, as Jen's testimony mentioned, the insecurity in her job as a nurse home visitor and the lower level of pay for a nurse is what led her to have to leave. She was a founding member of our NFP team, so dedicated to this program, and did not want to leave, but really said she could not support her family, not knowing if she would have a job in a few months' time or not. And with that, we lost her expertise, her skills, and more importantly for her and for the families we serve, the relationships she's built over time with these families that make NFP and other home visiting models so successful is that they work with them. We come into their home and they build trust in us so that we can really serve them so effectively and efficiently. And we lose that when we cannot offer job security and sustainability to both our clients and to our staff that serve them. So thank you so much for your commitment. We really appreciate all the work that you're doing on behalf of home visiting in the district.
Thank you. Thank you all for being here, and please make sure you submit your testimony for the record. We're going to go on to our next panel. Chris Bradshaw from Dreaming Out Loud, Mark Miller, who's the state ombudsman for the Office of DC Long-Term Care Ombudsman, Holly Eaton, who is also with the Office of DC Long-Term Care Ombudsman, Mark Lavoda from the Behavioral Health Association, Andrew Patterson from Legal Aid DC, Swapana Yuluri from Legal Counsel for the Elderly. Okay, I see Chris. So why don't you go ahead and get started?
All right. Thank you to the DC Council Committee on Health and Councilmember Henderson. I'm Chris Bradshaw. I'm the founder and executive director of Dreaming Out Loud. We are an organization that creates economic opportunities for the DC metro region's marginalized communities by building a healthy, equitable food system. I'm here to speak about the district's Department of Healthcare Finances 1115 waiver, which we believe is a critical piece to unlocking the economic and health potentials of the food system. 36% of DC residents are currently experiencing food insecurity, and there's a lack of infrastructure and availability that makes all of these experiences very challenging. These impacts fall primarily on Black and Latino households with children that also experience higher rates of diabetes, prediabetes, hypertension, and obesity than their counterparts across the district. In particular, Ward 7 and Ward 8, each of which are about 92% Black, lack the necessary food system infrastructure to access healthy and affordable food. Food insecurity costs the district over $100 million annually. Nutrition is a critical component of healthcare, and with other spaces using 1115 waivers to help to communities to access healthier food, we believe this can be a key driver for the district. When we think about what the potentials are, expanding nutrition services could open up procurement for local farmers, including urban farms within the district, production of healthy meals, medically tailored meals, and other services related to the impact on health of communities could be also key economic drivers, where we could source that produce, that meal production from district entrepreneurs, from spaces like the Marionberry Avenue Market. And we could keep that economic power within the district being spent on our community's wages, increasing and strengthening the tax base, and overall strengthening the district. Currently, there are not enough food production spaces. There's not enough food access points like grocery stores and markets that could all be better sustained with the type of revenue that could come from 1115 waivers that better localize the food system and allow our entrepreneurs and food makers and farmers to plug into the healthcare system to help drive more sustainability, living wages, and healthier communities. Thank you.
Thanks, Chris. Mr. Miller.
Thank you, Chair Henderson. It's good to see you and be with you this morning. I'm Mark Miller. I'm the DC Long-Term Care Ombudsman with Legal Counsel for the Elderly. There are two issues that I wanted to bring to the committee's attention this morning. One is the continued lack of staffing to serve EPD waiver beneficiaries. And the second is the need to develop a service infrastructure to meet the growing demand for home and community-based care. First, to the staffing of EPD waiver clients. Staffing is a consistent and common complaint that my office receives. Some home health agencies accept EPD waiver beneficiaries without the capacity, and in some cases, I think without the intent to provide full coverage for their assessed hours. Common gap is weekends and evenings, and we also have some clients that we've identified that have gone for months without full coverage. And that's important because the waiver clients are nursing home level eligible, so they need to receive these services to remain safely in their homes and in the community. DHCF has provided guidance on how to use, they can use two agencies together to meet their needs, but that doesn't always happen. So there continues to be a lack of sufficient staff. That's still a prevailing and consistent problem that we're hearing. We believe DHCF should prohibit home health agencies from accepting new clients if they cannot adequately staff the clients they're already serving. Once again, my office recommends that home health agencies be required to publicly report the number of EPD waiver clients they serve, the number of waiver clients that they are unable to fully serve, and the number of hours they're unable to staff. This is information prospective consumers need to make the best choice for their particular situation. Second, the need to develop a service infrastructure. The recent decision in Brown versus the District of Columbia has highlighted a system deficiency that has prevented scores of nursing home residents from being able to return to their homes in the community. To be clear, this is a complex issue, and it will require a citywide approach. Two biggest barriers seem to be, one, affordable and accessible housing, and the other being the inability to access the service hours needed so that people can safely return home. Indeed, the city's Olmsted Community Integration Plan listed housing as one of its top 3 priorities. Unfortunately, a plan without an infrastructure of services, including affordable, accessible housing, makes this meaningless for district residents that count on this. Helping nursing home residents go back to the community allows them to live with dignity and autonomy in the least restrictive environment possible. But it also frees up nursing home beds that the district desperately needs. The 2021 study that this committee commissioned showed that there were, in the last decade, we lost 439 nursing home beds. And ironically, the report also showed that DHCF is paying for 440 nursing home residents that are actually living in Maryland and Virginia. So we need those beds. We need those beds back. I'll close with this. There's obviously numerous interrelated factors impacting the ability of nursing home residents to return to the community. An adequate workforce to provide personal care services is certainly a significant piece of that equation. It's not a problem that's going to resolve itself. It will require multiple agencies and private sector groups working together, and I believe it will require the council's leadership. And finally, I just want to express my appreciation and gratitude to DHCF for working collaboratively with the Ombudsman program on both individual and systemic issues. We meet with them on a bi-weekly basis. They're exceptionally helpful. Thank you for the opportunity to testify today, and I'm happy to answer any questions.
Thanks, Mark. Holly?
Yes, good morning, Chairperson Henderson. I appreciate this opportunity to provide my testimony today. My name is Holly Eaton. I am the Senior Attorney for the DC Long-Term Care Ombudsman with Legal Counsel for the Elderly. I am focusing my testimony today on the most vulnerable DC residents receiving long-term care services and how the district is horribly failing them and their families, those receiving 24 hours of private duty nursing. These individuals have serious health conditions due to accidents, strokes that have left them bed and wheelchair bound, quadriplegics, paraplegics, threatened with a huge reduction in nursing services. One of my clients, a young man in his early 30s, who suffered a serious spinal cord injury, which left him unable to relieve himself without assistance, specifically requires catheterization every 4 hours. He does not have the manual dexterity to self-catheterize. It must be done for him by a nurse. To his credit, he works full-time as a journalist and is accompanied to work by his nurse who cares for him on the job. He's been receiving private duty nursing every day over the past 14 years. Then a year ago, out of the blue, his nursing agency was informed they would only be authorized to provide 6 hours of services a day, from 24 hours down to 6. Each subsequent authorization issued every 60 days has been for a different amount. First 6, then 10, then 0. Yes, 0, because the nursing agency failed to include the nurse's notes, and recently 9. Although he continues to receive the original number of hours while his case is before OAH, the threat of a significant reduction hangs over his head. DHCF contracted with Comagent to provide these 60-day determinations using something called an interqual tool to determine the range of hours appropriate for the services to be provided, which is reviewed by a physician to make a final determination. I, along with my fellow legal services attorneys, some who will be testifying today, who represent these clients, have asked DHCF for Comagent's documentation that explains what standards are being applied, but have not received everything responsive to our requests. We cannot represent our clients without full transparency of the standards being applied to deny our clients' services. Furthermore, and perhaps most egregiously, the hours proposed make no sense at all. My client's plan of care requires he be catheterized every 4 hours. Failure to do so puts him at very serious risk of harm and possibly death. Yet Comagent's reviewing doctors simply count up how much time it should take to catheterize a patient. 30 minutes, 6 catheterization amounts to 3 hours, plus medications and time to write up the nurse's notes comes out to a total of 6 hours. It defies logic that an individual who must be catheterized every 4 hours would get all 6 in a row, one right after the other, plus all medications for the day in a 6-hour period, and be expected to wait 18 hours until the nurse returns. These cases have been going on for over a year and are still unresolved. Add to that problems with the submissions by the nursing agencies that slow down the approval process and don't contain the information Comagent needs. This treatment of these vulnerable individuals is arbitrary and capricious. I ask the council to intervene to declare a 6-month moratorium on reductions in private duty nursing hours to allow all parties to open a dialogue about the problems with the process and the determinations that make no sense, require DHCF to provide the attorneys handling these cases access to all documentation necessary to represent these clients properly, and finally require DHCF to determine why the submissions of the nursing agencies are insufficient or improperly submitted and provide additional training or support so that these problems don't keep recurring. And I'd be happy to answer any questions. Thank you.
Thank you, Holly. Mark?
Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illness, substance use disorder, or both, including the 35,000 district residents that our 35-member organizations serve annually. Disruption to federal financial support for the district's Medicaid program threatens to destabilize the foundations of the district's overall health system. Scenarios being discussed would lead to the closure of dozens of provider organizations, termination of thousands of staff members, and loss of services, coverage, or both for tens of thousands of district residents. In addition to those direct consequences, the district and our neighbors in Maryland and Virginia would experience spillover effects as remaining providers needed to offer higher levels of more expensive care to those who failed to receive appropriate community-based services. Wait times increased and wait lists grew to access emergency and non-emergency services, and people with untreated needs with additional contacts with law enforcement, correctional institutions, and other non-healthcare entities. Let me turn to provide a few key points about Department of Healthcare finance efforts regarding benefit design and provider accountability. My written testimony includes additional details. We appreciate the goals of behavioral health benefit redesign efforts, and we have several recommendations for continuing refinement of that work. First, we urge DHCF and DBH to redouble efforts to align policy decisions and system configuration actions that over the past year have included frequent inconsistencies that, while generally small, have created significant cumulative challenges for the DBH provider network. Second, while DBH has an important leadership role in many parts of planning a permanent Medicaid reimbursable pathway for certified community behavioral health clinics, we urge DHCF to take the lead in the development and financial planning for the district's method of implementing the CCBHC prospective payment system. While working to improve the system, the Department of Healthcare Finance also has important tools to address the underperformance of the Department of Behavioral Health provider network. First, we urge DHCF to identify a way to suspend payment for services delivered by individual rendering providers with unacceptable performance records. Second, we urge DHCF and DBH to target efforts to relieve higher performing organizations of burdensome scrutiny, to guide well-intentioned but ill-equipped providers either to improve performance or to exit the network, and to remove bad actors. And third, the provider network also needs DHCF and DBH to continue to make thoughtful adjustments to workforce requirements and provider reimbursement. We thank the Department of Healthcare Finance for its ongoing efforts to advance high-quality whole person care for district residents, including those with behavioral health needs. I thank you for the opportunity to testify today and look forward to answering any questions you might have.
Thank you. Andrew?
Yes, good morning, Chairperson Henderson. My name is Andrew Patterson. I'm a senior attorney with Legal Aid DC. Thank you for the opportunity to present this testimony today. I want to focus my testimony on our continued concerns around long-term care services and in-home healthcare services for DC Medicaid enrollees. We remain very concerned about the staffing crisis that Mr. Miller spoke about earlier among home health agencies. Legal Aid continues to encounter clients who are not getting the full number of their approved medically necessary personal care aid hours through either Medicaid or the EPD waiver programs. This is a particular concern for individuals who either need a higher number of PCA hours or people whose approved PCA hours do not break down neatly into 7 or 8 hour shifts. People who are approved for 11 or 12 or 13 hours, for example, have extreme difficulty finding an aide who is willing to take the remaining 3 or 4 hour shift after the original 8 hour shift has expired. These shorter shifts are still critically important for this population to be able to safely remain in their homes, especially for people with significant limitations in ADLs, such as mobility, transferring, or toilet use. We applaud the DC Council for passing the Direct Care Worker Amendment Act and believe this is an important first step in addressing the staffing shortage, but more must be done. First, we encourage DHCF to implement a 1915J waiver program to allow for self-directed PCA care through the Medicaid state plan. Self-directed care allows people to identify and hire their own home health aides and is already an option for the EPD waiver enrollees through the Services My Way program. Expanding this option to the state plan should further reduce pressure on home health agencies and expand the overall number of available home health care workers. Critically, aides whose services are delivered through participant-directed care programs, those aides are often family members or friends who do have more flexibility to take shorter shifts than PCAs through home health agencies, who are employed through home health agencies. And second, we encourage DHCF and the council to continue exploring other financial incentives for PCAs employed at home health agencies to take shorter shifts, such as reimbursement for time traveled between different shorter shifts. And second, legal aid has also seen an increase in the number of people experiencing the reductions of Medicaid-covered private duty nursing hours that Holly just spoke about. In some cases, from a high number of hours, such as 16 hours or even 24 hours per day, down to 6 or 7 hours per day, despite no change or improvement in their health conditions. Of the reductions that we have encountered at legal aid, many of the notices incorrectly state that the person is either not dependent on life-sustaining technology or already receiving PCA hours as at least a partial explanation for the reduction in PDN hours. But this stance misunderstands the importance of PDN hours. Many PDN beneficiaries who have experienced reductions in their covered services rely on health services such as continuous feeding tubes, saliva suctioning, indwelling catheterizations, complex medication management, and wound care. Services that require frequent and constant monitoring, but that a PCA is not qualified or able to perform. Legal Aid, DC, and others have also noticed an increase in PDN hour reductions after DHCF adopted the InterQual assessment tool to determine how many hours are medically necessary. As Ms. Eaton also spoke, DHCF and their contractors have refused to release the full assessment tool and standards that are applied to PDN medical necessity determinations, allowing patients and advocates to receive only assessment summaries. Therefore, we encourage DHCF to release the full assessment and for the council to intervene as necessary to make sure that we have those standards and that legal representatives have those standards as required by law, and to make any changes that are necessary to ensure that PDN hours are available to individuals who require health services in their homes that PCAs are not able or qualified to perform. I submit the rest of my testimony in writing for the record, and I thank you for the opportunity, Council Member.
Thank you. Ms. Uluri.
Good morning, Chairperson Henderson. My name is Swapni Uluri, and I'm a senior attorney with Legal Counsel for the Elderly's Economic and Healthcare Security Practice. Thank you for allowing me to testify today. We assist older DC residents obtain and preserve public benefits, including the Medicaid, elderly and persons with disabilities waiver benefits managed through the DC Department of Healthcare and Finance. The EPD waiver provides home health aides to disabled seniors so they can age in place, and requiring annual assessments for the EPD beneficiaries whose conditions and functional limitations remain the same over time due to chronic or unchanging conditions is overly burdensome on DC residents. LC urges changes to DHCF's policy to allow for attestations from case managers to recertify beneficiaries for health services and to eliminate the need for unnecessary and onerous reassessments. LCE has observed and has received feedback from our clients that these yearly assessments impose a negative emotional and psychological impact on their well-being, causing them increased stress and anxiety. And in addition to the cumbersome and imposing recertification assessment process, these clients must also challenge these reductions in their services and benefits, even when their conditions have remained unchanged. And LCE does provide legal assistance to help clients challenge these proposed reductions through OAH hearings or reconsideration requests to DHCF, where the reductions are often reversed. However, the beneficiaries are still having to endure the appeals process, wasting their time and adding unnecessary stress and anxiety. One example of the harmful effects of the current process is an LC client who's legally blind and suffers from various physical and mental disabilities. Each year during his reassessment process, DHCF reduces his home health aides hours, and then he must spend months navigating the complex process of filing a fair hearing and requesting reconsideration to restore his hours. And the uncertainty surrounding whether he'll have an aide to help him exasperates his mental and physical health. Additionally, due to these disruptions, his home health care aides are sometimes not paid and his budget is not authorized. And the budget is what allows for funding for allocated beneficiary programs. And this has led to an instability in his care. And during one of these instability periods, he didn't have an aide, and he ended up using dishwashing liquid instead of ketchup, and he ended up eating moldy bread. And so these issues not only triggering his mental health conditions, but also impacting his ability to engage in normal activities of everyday life. And the time and resources spent on repeated yearly assessments for unchanged conditions could be better served on patient or government efficiency. It creates an administrative burden for caseworkers, healthcare providers, and the judicial system. And it also generates additional paperwork and delays service delivery, potentially leading to a serious gap in care. Improving the recertification process could also lead to significant increased fiscal benefits by reducing the workload for DHCF, who has to manage these in-person recertifications, and eliminating unnecessary hearings and reassessments. Lastly, obtaining a caseworker attestation that no change occurred in lieu of a full face-to-face annual assessment complies with federal Medicaid rules requiring annual assessments under 42 CFR section 44.1365E and 42 CFR section 441.302C2. This approach is still compliant because the provider would still conduct an annual evaluation of the EPD waiver beneficiary's level of need before submitting an attestation that a face-to-face reassessment is not needed. There are no provisions within the regulations that prohibit such an approach, making it a feasible and appropriate alternative to the current policy. Thank you again for the opportunity to testify, and I look forward to answering any questions you may have.
Thank you. Thank you to this panel of witnesses for your testimony and for your continued advocacy on behalf of your clients in particular, and the residents for whom you serve. Mr. Bradshaw, I'll start with you because everybody else was testifying about long-term care and behavioral health. But I want to express appreciation for the work that you all do with Dreaming Out Loud, and hear you loud and clear around wanting to make sure that local organizations also get to benefit from the food as medicine work that we're trying to do, as opposed to just very large organizations who frankly may be out of state and what they're doing there. So we'll keep an eye on that and continue to monitor it, and hope that you all can continue with continued success in terms of the work that you're doing in the district, because I've seen you guys out at the farmers markets and stuff. So thank you for that.
Thank you.
Okay. I want to, Ms. Hillary, I want to start with you. The testimony that you provided about that, the client at the last example, when there is a reduction in terms of hours, are they providing any explanation as to why? Because in this particular situation, nothing about the client's health disability has changed, right? They legally blind here, legally blind there, but somehow someone is saying, oh, you need less hours now. What's the reasoning here? Oh, you're on mute.
So they have to go through an inter-eye assessment, and depending on who conducted those assessments depends on how thoroughly they did it. And so we'll get the assessments and we'll compare them, and we'll talk to the client, and they'll say, oh, these questions weren't asked of me, or this information was never, they never asked me to provide this additional information. And so when we're looking at them, we're usually filing these reassessments and going through an appeal saying that they weren't properly conducted. The client wasn't asked these questions, so the assessment wasn't done in a thorough manner.
Okay. In another agency, the Office of Administrative Hearings, I think my days are running together, but let's just say that their hearing was this week. I think it might have been on Monday. Again, days running together. Anywho, OAH has reported almost a doubling. Actually, it's more than doubling of cases that they've been hearing from the Department of Healthcare Finance from FY23 to FY24. If my memory serves me correctly, I think they had something like 644 healthcare finance related cases in FY23, and that skyrocketed up to over 1,400 cases in the last year. And I'm imagining that some of it is related to some of this, right? Now, OAH's workload has increased simply because an agency contractor who is supposed to be doing this evaluation hasn't done their job?
Yes, Councilmember Henderson, it's everybody's workload. So it's DHCF's workload because they're having to do these reassessments. Because if we're saying that the hours are not correct and we're filing for reassessment, they're having to redo them. It's us as attorneys having, increasing our workload, contesting issues that aren't changing. It's OHS workload, so it's everyone's workload is being increased, and it's just not a great use of our fiscal dollars.
Yeah. Mr. Patterson, you raised in your testimony about the 1915 waiver in terms of self-directed care. Have there been other jurisdictions who've pursued this?
I imagine there have been. I don't know them offhand, but I know that this is an option in the federal law.
Right.
And one of the things that I think is most effective about the EPD waiver program is that it does have the self-directed option. And we've handled EPD waiver cases for years now. We were one of the organizations that received a huge influx of cases when the NRI assessment tool was first adopted back in 2018, 2019. And one of these persistent challenges has been the staffing issue that Mr. Miller and others have talked about over the years. So there are multiple issues that are still going on with the EPD waiver program, but one of the things that I do think makes it a little bit easier for people in that program is this self-directed care option, because
Right.
it's people that they know, it's people that they trust, it's people that maybe do have that flexibility to take a shorter shift, because again, especially for someone who has really high levels of needs with certain ADLs like mobility and transfer and toilet transfer. If someone needs an aid 13 hours a day and they only get it for 8 hours a day, they're trying to do those on their own. And that's when injuries or worse occur. And that increases the risk that someone is going to be institutionalized. So, as far as I could look into that, or we could have someone look into that and get back to your staff on some other states that have actually adopted the 1915J program for the state plan.
Right.
But it is there as a federal option, and we really do encourage DHCF to consider it.
I mean, I think that this is an interesting option. I'm not going to, we've heard testimony in prior hearings from individuals who use the services my way, and that's not panacea either, right? There could definitely be issues that happen with that especially if, there are issues in terms of payment processing.
Yes.
But then, if the workforce shortage is the workforce shortage, and while this would allow for other individuals who may not be a certified nurse assistant or home health aide to participate in the caregiving, then the question is, what if somebody opts for this and then they still aren't able to find a qualified individual to be able to provide the care, which is always going to be sort of the challenge.
Sure, and I'll just say I think it's a good point that there is no panacea. I mean, and at legal aid, in terms of some of the problems that we see with Services My Way, a lot of it is with trying to get the contractor who is responsible for administering that program to be responsive, to do the things that need to happen for those aides to be able to just go ahead and serve. I mean, I have several clients right now, and I'm trying to follow up with case managers. I'm trying to follow up with GT independents to say, hey, look, what is the status of this? These people, they have identified people who they want to be their health aides. Those health aides or prospective health aides have submitted the required documentation, and they're not hearing anything yet, or it's been months and months until they can sit down and have the budget meeting where everything is approved and those services can start. And as you say, people can actually be reimbursed for the services, because you're right. I mean, if someone is enrolled as an aide through Services My Way, but they're not getting paid, they're going to have to go do something else. So I do think that there are multiple areas that need improvement in terms of person-directed care, along with the EPD waiver in general. But this staffing shortage has been a really critical problem for several years now, and I think kind of doing everything we can to just increase the number of people who can provide these care services to Medicaid beneficiaries, I think would be an important step.
Okay. I'm really sorry to do this, but I just need to take a 2-minute pause because my little intern is screaming. So just give me just a minute. I'll be right back. Okay, the joys of working from home. All right. Where was I? Okay, EPD waiver. That is what I wanted to talk to Mark and Holly about. When we talk about the long-term care issues, and I think we heard on the not the last panel, but it's the first panel of the hearing. The developer from the residences at Kenilworth and sort of talking about how there are not a lot of places available in the district for individuals to go. I think, Holly, you mentioned that the number of nursing home residents who were paying for Maryland. For Maryland. Mark, I know you said you guys have these ongoing conversations with Department of Healthcare Finance. What's their response on some of these things, particularly the lack of staffing to serve EPD waiver clients, and then also, our declining number of nursing home bed availability in the district?
Yeah, it's a multi-factored sort of problem, and they've been aware for years of the staffing issue, and we've talked sometimes about what's the incentives, how do you make it easier for reciprocity, so that if you have aides that are in Maryland or Virginia, that they can more easily come into the district, and that might involve a whole host of things, including giving them some sort of a parking pass so that they can, park on our streets and, for a number of hours to serve the clients they're serving. So there's a whole host of things that we've talked about, but the problem is the numbers aren't there. And I know that they have, I think the council recently passed something that said we can, instead of being 18, you could be 16.
Yes. Yeah.
I mean, personally, I don't necessarily agree with that, just because, you're talking about minors and other
Well,
issues.
it's not for minors in the house. It's
Yeah, right,
only at facilities where they
the nurse
are
home.
properly supervised.
So I mean, those are the sort of things that are creative that I think DC has to start looking at, to attract more people and to allow more people to be able to come into DC and provide those services. I don't know what the pay scales are, to be quite honest. I know with nursing homes, one of the issues we talked about nationally is it's not necessarily a lack of staff available, it's a lack of good jobs, good paying jobs. And so I don't know if there's an equivalency with personal care aides or not. So
I mean, I think it's a similar thing, and thanks for sort of plugging that, Mark. But with the committee, we've been trying to sort of address some of the workforce issues by allowing the additional flexibility for Maryland and Virginia. We lowered the licensure age for folks who are working specifically in facilities. We have programs at there's a charter school in DC who's doing this. OSSI has launched their Advanced Career Technical Center that specifically has a program track on nursing. So again, right, trying to build in this workforce of individuals, but perhaps the biggest issue is around pay. To your point of good job, right? If I can make more money at Starbucks and sort of have I'm not going to call it less stressful, because some of these coffee shops can certainly be a stressful environment, but it's certainly not as physically laborious as having to help someone downstairs or do all of these different things. I think people are going to take that option. And so when we passed the direct care worker bill to raise the minimum wage, it was out of acknowledgement of this workforce issue that we're having at the same time that we have this growing number of individuals who want to age in place.
right.
And we literally don't have the people to allow for someone to do that. And I think that's incredibly sad, right? They now have to either sell their home or give up their home to move into a facility that's probably going to cost them more money just because we don't have the available workforce. And I feel like this is a solvable issue.
It takes time, obviously, but there's been time, and it's just one of those things, because the demand will continue to increase. So we have to have a corresponding increase in workforce availability, and we're just not there at this point.
Yeah. You know where else we need workforce? I'm sure Mark will tell you, is in behavioral health.
Yeah.
Mark Lovato would say that that is also one of those things. Mark, I want to ask you something that I asked other folks, because obviously you guys have these ongoing conversations, not just with Department of Behavioral Health and healthcare finance and otherwise, but if there is one question that you feel like the committee most certainly should ask and get a response to on the record from Director Turnage and his team, what would that be?
Oh, that's a great question. I'm not exactly sure. There's so many questions. I do. This is the bigger question, and maybe they don't want to address it at this point because I think they're appealing the Brown decision. But there is a question, well, how do we make a real active, actionable homestead plan so that we can move people out of nursing homes back to a less restrictive environment, mainly home. Although some of them could go to these newer assisted living buildings that are taking the Medicaid waiver. But I think it centers around that homestead plan because it's more than just nursing homes and getting people out. It's providing affordable, accessible housing, and then also the supportive services that people need to be able to stay independent in the community. I think it's terrible. I mean, it's just a terrible thing that we have people that have lived all their lives here, have given to the community, have taught our children, put out the fires, all those things, and then through no fault of their own, all of a sudden can't afford to stay in their own home because they've got a chronic condition or something. So that's the big question. I mean, we could address some of these little ones, but that's, I think, really the fundamental question that has to be addressed of how are we going to build that infrastructure?
Yeah. I'll pose the same question to Mark Lovato as well.
Well, I mean, it's the same question, right? You talked about all of the gaps in the behavioral health continuum earlier today. How are we going to build that infrastructure? We know that we need brick and mortar. We know that we need workforce investments. We know that we need adequate reimbursement rates. How are we going to build that infrastructure? And where is the plan for prioritizing those investments? Because we may not be able to do it all. We may not be able to do all of it at once. But how do we collectively have a conversation about getting people into at least better levels of care than the care that they're forced into when the option that they really need isn't available?
Okay, thank you. We'll definitely bring this up with the government witnesses. Thank you so much to everyone who testified. I don't have any further questions on this panel. Please make sure you submit your written testimony for the record online. All right, we're almost there. Gonna go to our next group of witnesses. I'm actually gonna split this final into two panels just because it's not quite enough, but it's also a lot of folks. So Makita Vanderpew, leading HDC, Ian Paragal from DC Coalition of Disability Service Providers, Rachel White from DC Action, Kurt Gallagher, and Lindsay Niles from Disability Rights DC. Once again, you need to accept our invitation to become a panelist. Also, it's helpful if you have a username that is not the name that I called. Please, either message us or let us know, because we're not going to promote just an iPhone or an initial. Okay. I see leading age, but they haven't been promoted yet, so we'll just We'll start with Ian and then we'll go to Makita when she joins. So Ian, when you're ready.
Thanks so much. Good afternoon, Chairperson Henderson. I'm Ian Parago, and I serve as the Executive Director of the DC Coalition of Disability Service Providers. The coalition currently represents over 50 provider agencies supporting over 2,300 persons with intellectual and developmental disabilities and employing over 7,000 staff. Member organizations provide home and community-based waiver services as well as ICF supports. On behalf of our provider agencies and those whom we support, we want to recognize the leadership of Director Byrd, and in particular, the transparency and accountability demonstrated by Senior Deputy Director of Finance Angelique Martin and Associate Director Sam Woldehorgas. Director Byrd is always available to provide direction and answer questions that then arise in our sector. And as the coalition's primary conduit, Ms. Martin's follow-through and efforts have helped the DD provider organizations halt the exodus of direct support workers from the industry with thoughtful implementation of the DSP wage enhancement program. Towards the end of 2024 and continuing into 25, DHCF and the coalition have connected in a data-driven analysis designed to justify heightened fiscal support for the industry's nursing staff who remain underfunded for ICF, DD waiver, and actually home health as well. And to that end, we continue to seek competitive funding rates to address our nursing shortage, which is really a renewal of our oversight and budget recommendations from 23 and 24. As outlined in our written submission, funding in for our nursing staff lags well behind the wages that these same nurses can earn in more traditional institutional settings. We do recognize that there are nursing needs throughout the region, but we are seeking funding so that our IDD providers can pay their nurses at least a competitive rate with the hospitals and governmental employers. We recommend that the hourly rates that form our reimbursement models be adjusted to at least those which the district is paying for nursing home staff. So as noted by Mark Lavota, we also want to take this opportunity to make certain that the Committee on Health recognizes the potential disruption, more so devastation, in health and human services that would occur if the district's FMAP were to be reduced from 70% to 50% as proposed. As provided in my written testimony, the FMAP reduction in the district appears with line item specificity on the list of potential fiscal savings targets developed by the Republican coalition in preparation for the upcoming budget reconciliation bill. While we understand that this hearing has limited impact upon federal policy, it is an opportunity to ensure that the council and DHCF are actively developing a working glide path with specifics to ensure continuity of services within the DD supports and home health sectors. At the end of the day, without funding for those receiving residential and ICF supports in particular, residents will be forced into more congregant settings like institutions, which the district eliminated as a service option decades ago, or the even more costly nursing home option. The coalition strongly encourages the DC Council's Committee on Health to be actively engaged in discussions involving this potentially far-reaching health system change that will not only impact our health systems and services, but also businesses, employment, public safety within the district. So to wrap up, plans should be developed now that contemplate the potential funding formula change so that beneficiaries and residents are not caught unaware. Greater public discourse relative to the impact associated with an FMAP reduction would lead to heightened visibility and advocacy, and that's something we don't see yet in the media and mainstream outlets. Thank you for the opportunity to provide this testimony, and I'd welcome any questions.
Great. Thank you so much, Ian. Just to note for the folks who are testifying, we recognize we've had some technical difficulties with our clock, but we're keeping time on our end. So let's help each other. Just be mindful of time. And I'll do my best. Rachel? Rachel, if you're speaking, you're on mute. Okay, there we are.
Can you all hear me?
Yes.
Okay, perfect. Okay.
Hello, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunities to testify today regarding the Department of Healthcare Finances performance, and particularly the need to ensure access to services for youth exiting the justice system. My testimony will focus on the urgent need for streamlined Medicaid enrollment and behavioral health services for justice-involved youth as they transition back into the community. Justice-involved youth experience significant challenges in reestablishing Medicaid coverage upon release from juvenile justice facilities. The newly enacted Consolidated Appropriations Act requires Medicaid coverage for justice-involved youth to be reinstated 30 days before their release and mandates case management support. However, it is unclear whether or how DC is implementing this law. In 2021, fewer than 1 in 5 justice-involved youth ages 16 to 18 reported being enrolled in Medicaid upon release. Nearly 2/3 of justice-involved youth reported not having a primary healthcare provider. Nearly 2/3 of youth reported having physical health conditions, while approximately half reported substance use or mental health challenges. DC's Medicaid enrollment backlog results in processing delays of over 45 days for nearly half of applicants, leaving many youth without coverage when they need it the most. Medicaid access can be improved with automated enrollment and expanded case management. Our recommendations are to number one, automate Medicaid enrollment. DC should use the provisions of the Consolidated Appropriations Act to mandate that the Department of Youth Rehabilitation Services submits Medicaid re-enrollment applications 90 days before youth's release to prevent lapse in coverage. The CAA Medicaid provision appropriates grant funding to the Department of Health and Human Services, so federal grants should be leveraged to create an automated system that streamlines applications and renewals. Expand case management services. The Department of Behavioral Health and the Department of Healthcare Finance must collaborate to ensure targeted case management is provided at least 30 days before young people are released. And lastly, enhance support for guardians and youth navigating enrollment. Some justice-involved youth may face challenges in navigating Medicaid enrollment independently. DC should establish dedicated navigators to assist both youth and their guardians in completing applications and accessing services. The Health Benefit Exchange has seen great outcomes through their use of healthcare enrollment navigators, and this model should be replicated. Ensuring Medicaid access for justice-involved youth will provide them with the vital physical and behavioral healthcare services, improve continuity of care, and reduce recidivism. By implementing these recommendations, DC can remove bureaucratic obstacles and support youth in successfully reintegrating into their communities. I urge the committee to prioritize these recommendations and hold the Department of Healthcare Finance responsible and accountable for implementing these solutions. Thank you for your time and commitment to improving healthcare access for justice-involved youth. Thank you.
Thank you. Kurt.
Good afternoon, Councilmember Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Kurt Gallagher. I'm the Executive Director of the DC Dental Society. I will supplement my oral comments today with written comments. We, as you heard from my colleagues and other healthcare associations, are all aware of the risks to Medicaid funding in DC. The District of Columbia Dental Society stands ready to support the effort to defend Medicaid funding and the 70% FMAP for the district. I do also want to provide a reminder of the fact that funding for dental procedures under Medicaid have not increased since 2007. Well, the fees have not increased. We've engaged in discussions with DHCF over the past year and how these fees could be increased. And we were encouraged by those discussions through late last year about the prospect of fees being increased for targeted procedures and by broader procedures. We look forward to receiving detailed specifics on those modified fee schedules, and we're optimistic that the fees will be implemented in the near future. The low fees paid under Medicaid for covered dental procedures create a serious barrier to care in DC, as dentists drop out of the Medicaid program or shutter their practices because they care for a high percentage of patients who rely on Medicaid. This puts more pressure on those remaining service providers and healthcare qualified health centers that accept Medicaid patients. We face the risk that funding for the entire DC Medicaid could be cut. And depending on the level of that cut, it's possible that coverage of dental procedures could be terminated because DHC views dental care as an optional coverage. And that's as if the person's health and well-being ends at the threshold of their lips, which we know is not reality. Tragedies of the past provide a grim reminder that oral health is indeed part of overall health. There was a resident of Prince George's County who passed away, a 12-year-old boy named Diamante Driver, and he died because he could not receive timely dental care to treat a tooth abscess. And there are other similar tragic cases that have occurred over the recent years. I asked this committee to consider the impact on the health and well-being of DC residents if dental procedures are no longer covered by Medicaid, and if fees are increased to increase the number of providers who enrolled in the program. There are many unknowns in this current situation, but what I can state unequivocally and without any doubt is that if DC residents cannot obtain dental care under Medicaid, including preventive care, they'll turn to emergency rooms to seek assistance when they have a tooth abscess, a toothache, a cracked tooth, a broken tooth, or suffer other dental emergencies. Our priority is defending funding for DC Medicaid, but also let's look to the future and ensure that DC provides meaningful total health coverage for residents, which includes funding for medical and dental benefits for all DC residents. Thank you again for the opportunity to testify, and I would welcome any questions you might have.
Thanks, Kurt. Lindsay?
Good afternoon, Chairperson Henderson. My name is Lindsay Niles. I'm a managing attorney at Disability Rights DC at ULS. We're the designated protection and advocacy program for people with disabilities in the district. We appreciate the opportunity to testify. I'm also co-counsel in the Brown v. DC decision. I was actually not planning to testify about this landmark decision in that case, but I would like to briefly clarify a few things about what the case is about in light of Mr. Miller's comments. First, the case is about the district's failure to provide DC residents in nursing facilities help to access community-based services and housing options needed to transition back to the community. Although there are some barriers to transitioning to the community, as highlighted by Mr. Miller, the decision acknowledged it's the district's responsibility to address barriers to transitioning to the community, including by ensuring adequate capacity in home and community-based services and helping them address barriers to identifying housing in the community. I also wanted to clarify that the district has not yet appealed the decision, but is seeking to amend the judgment and the injunctive relief ordered by the court to create an effective system of transition assistance so people can live in the community in line with their rights under the ADA. And if the committee has any additional questions about Brown, I'm happy to answer those. In terms of my plan statements, we also have concerns regarding the increase in improper across-the-board reductions of life-sustaining private duty nursing services. DHCF has informed DRDC that its contractor, Comagin, started using the interqual assessment criteria to make hours determination for PDN services in January 2024, which I understand resulted in an increase in PDN service reduction cases in OAH. DHCF also acknowledges that there are across-the-board denials of PDN services in its oversight responses. As described in our written testimony and described by Ms. Eaton and Mr. Patterson, DHCF has also failed to provide beneficiaries and their counsel access to ascertainable coverage standards for PDN services in violation of their due process rights. DRDC has also expressed concern to DHCF regarding its regulatory requirement for periodic reassessments of PDN services every 60 days. This has resulted in unwarranted reductions in PDN hours, regardless of beneficiaries' demonstrated need. DRDC has a client who faced a second threatened reduction in PDN services via a new 60-day reassessment, despite the client's hours just being restored in OAH and no change in health status. PDN providers who challenge reductions on behalf of their patients have also reported this issue. We urge DHCF to take steps to address this issue, including by extending the 60-day reassessment period. As previously testified, DHCF imposed a 16 hours per day cap on self-directed PCA services that has resulted in EPD waiver enrollees not being able to find home health agency staff to cover their remaining 17 to 24 hours a day of PCA services. To resolve this issue, we join our colleague, Mr. Patterson, to urge DHCF to opt into the 1915J state plan option to provide self-directed services for all state plan beneficiaries. It's our understanding that DHCF is declining to opt into this option. This decision places persons with disabilities at risk of placement in nursing facilities at greater expense to the district and in violation of their rights under the ADA. And briefly, I want to touch on one more issue that in February 2025, the HCF began using a new vendor, Telligent, to conduct inter-RI assessments. Although the inter-RI tool has not changed, this transition raises concerns about whether Telligent's implementation of the tool will result in further cuts in PCA services. Additionally, the transition has lacked transparency. We urge DHCF to meet with and share with DRDC and other stakeholders besides providers policy information regarding the transition. DRDC has also received a report that Telligent has a backlog in scheduling assessments, which we also urge DHCF to promptly address. Thank you again for the opportunity to testify, and I'm happy to answer any questions.
Thank you. All right, Makita.
Good morning, Councilmember Henderson and members of the Committee on Health. My name is Makita Vanderpoy, and I am the Executive Director of Leading Age DC, an association representing mission-driven organizations serving older adults across the district, including nursing homes, assisted living, affordable housing, senior villages, home and community-based services, and lifetime communities. I'm also a Ward 5 resident and an active member of the District of Columbia Coalition on Long-Term Care's Workforce Development Committee. Today, I'm here to share Leading Age DC's appreciation for the important work of the Department of Healthcare Finance and to make recommendations to further shared goals for a district where everyone can age well and thrive. Providers in our aging services network value the critical support and communications they receive from DHCF, which helps them resolve issues related to reimbursement, managed care organizations, and district contractors. Leading Age DC members, primarily nonprofits, are committed to providing high-quality care. However, a severe shortage of direct care professionals, including home health aides and CNAs, threatens the capacity of these organizations to carry out their important missions. This shortage is exacerbated by the rapidly growing older adult population and the current trends in the numbers of individuals who are trained and licensed to care for this population every year, which is an area of profound concern. This complex issue offers us an opportunity. I've heard a lot of other folks who are also raising similar challenges around this. And a multi-sector plan for aging is an example of one promising emerging model. An MPA, multi-sector plan for aging, is a multi-year blueprint for restructuring state and local policies and convening a wide range of cross-sector stakeholders to collaboratively address the needs of older adult populations. They're designed to create a coordinated system of high-quality care and support services that promote healthy aging, independent living, and social engagement, while also addressing issues related to healthcare, housing, transportation, and other social determinants of health. A coordinated multi-sector task force will bring together expertise and perspective needed to assess and address the complex needs of our aging population. This task force should be sure to focus on interagency collaboration and private-public sector collaboration and communication to streamline services and ensure a holistic approach to addressing the needs of older adults. Workforce development, of course, implementing strategies to improve recruitment, training, and retention of direct care professionals, including fair compensation and career advancement opportunities, and sustainable funding to identify long-term funding sources that will support training scholarships, service accessibility, and reimbursement rates that allow providers to offer competitive wages and cover the true costs of care. This is a complex problem requiring the support and strategic thinking of experts and officials dedicated to finding long-term solutions for our current workforce crisis. Leading Age DC, our members and advocacy partners across the continuum are well poised and eager to join district government in collective action to ensure that our valued elders are able to access the high quality care and services necessary to age well and thrive. Thank you so much for your leadership and for the opportunity to testify today. I welcome any questions that you may have.
Thank you. And thank you to this panel of witnesses. Thank you to this panel of witnesses. Ms. Niles, I want to start with you. When you all have had conversations or not with regard to the 1915 waiver Has Department of Healthcare Finance explained what their hesitancy is?
So we don't know exactly why the district has chosen not to opt into the 1915 J estate plan option. It certainly would be a mechanism, although not a panacea, as you acknowledged, to address the staffing shortage issues for someone to self-direct their care. And this is an option where someone would have to identify at least two aides that could service them in the event that one of the aides was not available. So it is a system that could address a lot of the workforce pressures that we're dealing with. So we're not sure why the district doesn't want to elect that. I think it would be a really important question to ask them when you talk to the director. But we certainly know of at least some jurisdictions. I know in Maryland, they have our neighbors in Maryland, and I believe in Virginia have elected to use this option, and it ultimately would save the district more money in the long run because of the risk of folks being warehoused in nursing facilities at a greater cost to the taxpayers.
Okay, we'll definitely follow up with them on that. Mr. Gallagher, if you're still with us, have you all received any information on timeline for the new fee schedule?
We haven't. The agency I mentioned is taking a pause given the threat to the FMAP, and that may be what's happening. We're expected something early in 2025, but we haven't received those details yet.
Okay. This is like particularly poignant. So there was going to be a witness who testified earlier today about her situation trying to find dental coverage for her son. And she'd been trying for weeks to get her son an appointment to find a dentist who does pediatric, who also takes Medicaid. And they would get referred to someone, the appointment will get canceled, the appointment will get canceled, the appointment will get canceled. Her son had an infection, had a fever. And I literally had to involve the CEO of a managed care organization to finally deal with this situation, which frankly makes me question the network adequacy of all of our MCOs when it comes to dental coverage, especially knowing that we have so many dentists who are continuing to opt out of the program because the reimbursement rates are abysmal.
Absolutely. And
go ahead.
I was going to say, and the solution really is bringing those rates up. They haven't changed. They haven't increased since 2007. Now the number of procedures covered has changed, and there've been expansions. But if you look at the fee schedule from 2007 versus 2025, that they're identical, with the exception again maybe some procedures that are on the list and some that have been added.
Okay, we're definitely going to follow up on that and get some more answers on that front. Ms. White, thank you for being here and for your continued advocacy, especially with regard to youth experiencing homelessness. The delays that you described in terms of young people who are able to get connected to Medicaid services, what do we think is the driving factor here? Is it paperwork not being submitted in a timely fashion prior to a young person's release, or is something else going on?
Right. It's a variety of reasons. The paperwork is an issue with the passage of the Consolidated Appropriations Act, which went into effect January 1st this year. It requires caseworkers in juvenile justice facilities to apply for Medicaid at least 30 days before youth ages out or is exits out of that system. But the data supports that that's not happening. And so it could be an implementation issue, or it's only been a month since it's been required. That can be an issue. Youth who are exiting out, who are not connected to a parent or guardian, may have difficulty navigating Medicaid on their own, and therefore there's a lapse in care. Because what happens is youth will have Medicaid, they will become involved in the juvenile justice system, and then they don't have Medicaid anymore because they receive health care through the juvenile detention center through Unity Healthcare. But then when they age out, they're not automatically, not age out, exit out of the system, they're not automatically enrolled. And so there are parameters in place to ensure that it doesn't happen, but youth are falling through the cracks.
Okay. And sorry for that. We're trying to test a new feature. That's a new one. I didn't know that it would do this sort of sound. That's
No
good.
problem.
But thank you. Rachel, we'll follow up on that, not just with healthcare finance, but also with DRS. This is one of those things where it's like, okay, which agency is the lead here in terms of being able to resolve the issue in a more timely fashion. So I used to be on judiciary. I'm not anymore, but I still go to their hearings and ask questions. So we'll follow up with DRS about that. Ms. Vanderpue and Ian, thank you for being here and for the work that you guys do on behalf of your clients. We've had lots of conversations about some of the issues that you all raised. So I don't have any specific questions for you all, but we're definitely gonna dig into this issue a bit more. I think, like I said before, the number of residents who are entering into that long-term care age, or just seniors just in general who might just need some additional assistance, it's not shrinking. And so we got to figure out how we are able to provide some additional support to individuals, especially given all that some of these folks have given to our community. But if you could just be sure to please submit your testimony for the record, and then we do have a lot of questions about some of the disability services and the waivers and all of that that we'll be asking Director Turnage and his team.
Mine's already submitted.
All right, thanks. Thank you.
Thank you.
Okay, so we're gonna go to our last panel. Maria Gomez. I love that it says private citizen. I'm laughing because Maria's Mary Center through and through. Let's see who we have. Dr. Monique Powell Davis from Mary Center, Dr. Richard Gasker from Mary Center, and Jabron Eubanks from 1199 SEIU.
Should I start?
Give us just 1 second.
Okay.
Okay, when you're ready, Ms. Gomez.
Okay, great. Thank you. Councilmember Henderson and members of the Health Committee, I come before you today as a public health nurse and healthcare executive for over 30 years to present testimony on the Nurse Family Partnership Home Visitation Program, also known as NFP for today. The NFP program began with a noble vision, initially funded as a pilot by philanthropic dollars to Mary Center for 3 years. The goal of this seed funding was twofold: to demonstrate the effectiveness of the NFP evidence-based strategy, and two, to get the buy-in of the Deputy of Healthcare Finance to legislate Medicaid reimbursement through the submission of state plan amendments to CMS. I think we're tired of hearing this today, but the approval of this plan will ensure the sustainability over the years of home visitation in our city, which Mary Center and many other organizations have been doing for over 3 decades. As of today, this plan has not been executed. Currently, the Department of Healthcare Finance and the Council collectively support the NFP program with a substantial funding of $325,000 from just local dollars. However, this amount, without the Medicaid match, is insufficient to meet the high stakes involved. Those high stakes are that the maternal and health outcomes in this city remain among the poorest in our nation, particularly in Ward 7 and 8. The NFP has shown remarkable success in reversing this disheartening trends, offering tangible improvements at a cost of under $200 per family. The DC Council has recognized the importance of this program by passing legislation to establish a mechanism for Medicaid reimbursement. Furthermore, the Office of Chief Financial Officer has confirmed the availability of funds to support the NFP for 4 years starting this September. or October. However, despite this positive legislative and financial assurances, it appears that a technicality within the legislation, specifically, as you have said, Councilmember Henderson, the use of must, quote unquote, versus may, quote unquote, is causing unnecessary delays. Such a minor semantic issue should not overshadow the greater mission of NFP programs and other home visitation programs, which is to enhance the maternal and infant health outcomes of our city at a time when there's so many other stressors affecting the well-being of our community and the healthcare workforce. I earnestly appeal to the mayor, to the deputy mayor, and to the council to come together and look beyond the technicalities and focus on the bigger picture. Allowing a program with such a profound impact to shut down over a few words in the legislation would be a disservice to the mothers and infants who rely on this program and their healthcare providers. We see too often that when there's a willingness to execute on a business plan project in this city, we rally and we move mountains to get it done. So why should we not provide the first and greatest head start to our children, as the little precious soul that I just saw on the screen, which are health and well-being for our mothers, our children, and our families in wards 7 and 8. Home visiting strategies ultimately save lives, and they have, and I've been a witness. Thank you for the opportunity today and for your support, Councilmember Henderson. Let us resist and stay safe.
Thank you, Ms. Gomez. Gibran.
Good afternoon. Thank you for the opportunity to testify at this hearing, performance oversight hearing today. My name is Gibran Eubanks. I'm the political organizer with 1199 SEIU. We represent 400,000 workers across the healthcare continuum up and down the East Coast, with thousands of healthcare workers in hospitals, clinics, and skilled nursing facilities in the District of Columbia. We fight every day for fair working conditions and livable wages, and I'm here to testify on behalf of our members and all the district's healthcare workers who are struggling to make ends meet on low wages and are unable to provide the critical care for their patients due to severe staffing shortages. I'd like to commend you, Councilmember Henderson, for introducing the Certified Nursing Amendment Act. And we've been honored to be a part of the DC Coalition on Long-Term Care, which helped build out this bill by identifying solutions to the direct care workforce crisis. This bill does many things that will help relieve issues in the workforce, such as establishing a new credential for direct care workers to replace home health aides and certified nurse assistant certifications. This is crucial to our members directly because our CNAs at skilled nursing facilities often moonlight as home health aides to make ends meet. This bill also allows those certified in Maryland and Virginia to practice in the district. But the key component that I would like to highlight from this bill is that it establishes an average wage for direct care support services. As we know, DC ranks last among all states for wage competitiveness in direct care workers. We also know that the direct care workforce is predominantly composed of people of color who have historically been grossly underpaid and undervalued. The stories I hear from our members are heartbreaking. We held a screening recently with a panel of workers, patients, and family caregivers. One of the patients that a member of ours cares for spoke heavily to her commitment for caring for him. He spoke on how she takes 2 buses and an Uber to get to his location. And through tears, he said he loves her and that she is the only person in the world who truly cares about him, as his family stopped checking on him a long time ago. As touching as these stories are, there are opposite sides of the spectrum. I also hear stories of verbal and physical abuse of our workers, the mental burden that this kind of work brings, violence in the workplace that goes unreported and disregarded. And this job simply just isn't for the weak. And it's time that we pay these workers what they truly deserve. Lastly, I'll speak a little bit about my personal experience. As someone who had a family member who battled Alzheimer's for 12 years, I fully understand firsthand the importance of this work. My aunt was bedridden and couldn't do anything for herself. She needed a home health aide and a personal caretaker. Our home health aide, Ms. Sylvia, became a lot more than just a worker. She quickly became family. My uncle was a politician and was away from home away from home at a lot of community events and fundraisers and other work-related activities that require much of his time and attention. And it was Miss Sylvia who would feed and bathe and read to my aunt. My aunt was able to age in her home. She took her last breath in her home around people who loved her, including Miss Sylvia. So families like mine depend on you all to center the needs of our elderly and disabled residents. And it's time that we prove to them that we truly care and value for not just their lives, but the work that they do. I thank you for giving me an opportunity to testify today.
Thank you. Thank you to this panel of witness. And Gibran, thank you for that deeply personal sharing of just how important these direct care workers are, not just to the clients that they serve, but also the families for which they serve as well. In having conversations with your members, there are a variety of things that come up, and we've tried in some ways to address some of them. Not all of them have been fully implemented, right? In terms of like, let's streamline the licensure process. Let's make it easier to get folks in, especially if they are already credentialed in Maryland and Virginia. We've passed legislation around raising the wage, although we haven't had that funded just yet. But are there other things that we could be doing to try to make it easier to retain good talent in this field?
I think about if the issue is highlighted how it should be. And I think that sometimes when we have kind of these hearings, they're not able to be here themselves to kind of speak to what they go through on a day-to-day in their workplace. And I think it's about just making sure that this issue is pushed to the forefront. Of course, we understand the political climate and all the things that are going around in the world today, but it's often just that mental burdensome of not only do they feel unappreciated but unheard, right? They're not able to have a representative who's there who really understands the crucial, like the impact of some of these issues that they're facing. So of course we DC and parts of Maryland that we represent aren't exempt to what are the major issues at hand of just the cost of living right now and not being able to pay for certain things like their grandkids mouthpieces for their football teams. And I think that with paying them more, to be frank about it, is something that would really show them that we're taking this issue seriously and that we do we are supportive of the work that they do. So again, I mentioned a lot of the things in the bill in there that will help with recruitment and some with, but as far as like retention and the turnover of the work, it's like once they're hired and they actually have to go through certain things, and a lot of people are just they stick through because they care for the patients, right? Our members truly, they never put themselves first. Their main concern is about the patients and them not being able to provide the quality care that the patients deserve. So I think with increased wages, that'll help in the long run with retention and making sure that we have safe staffing in these facilities as well, because workplace violence is increasing as well.
Thank you for that. Ms. Gomez, thank you so much for being here and for all the things that you have done for the community, but also your continued advocacy on behalf of the NFP program, which I think is incredibly valuable. I think your testimony struck the right tone. So I don't have any additional questions on this. I think, yeah.
Yeah.
Thank you.
Well, I really appreciate your support, and I know that DC Healthcare Finance also says that they support it, but I think if we can come to some consensus, I think this is the time. I mean, this is going to be a blow to so many families that are already feeling like their world is coming apart at a national level. We don't need this additional thing. And seeing your beautiful daughter, it's a privilege to have had my own daughter, and so many of us in the city to have had the privilege to have the means and the knowledge and all of that to care for our children. So many of our community does not, and they just need that little support to make sure that our children, as I said, get the first Head Start. We worry about Head Start when children are at school, but it starts in prenatal care.
Correct. It certainly does. And so, like I said to the earlier witnesses, we're certainly going to keep pushing on this particular issue and
anything I can do.
Try to make sure. We'll definitely be calling you. Okay, so that's the last public witness that I had who has signed up. For individuals who wanted to be here, but life was lifing today because of the snow and schools being closed. You still have the opportunity to submit written testimony for the record. The public witness testimony, well, the record will remain open until February 26th at 5:30 p.m. You could submit your written testimony on the council's hearing management system at dccouncil.gov/hearings. We are currently in the process of trying to reschedule Deputy Mayor Turnage's testimony, but once that date is confirmed, we'll certainly make sure that the public is aware of when and where it will be taking place. And with that, this meeting is adjourned. Thank you all so much for being flexible, and please stay safe on the roads. Thank you.